Just be
Very,
aware.
very busy.
My dear. But I just on background, don't worry.
All right. Thank you, sir. Thank you so much, sir. Dr. Adeyanju, please, it's over to you. And we all know the drill. We read it, she answered the question and explained. And if we have any clarification, we ask before she goes to the next question. Please try to communicate and interact so that we'll carry everybody along. Thank you so much. God bless. Over to you, Dr. Adeyanju. Dr. Siri, please, from tomorrow, this is what you'll be doing now. You and Adeyanju. Thank you.
Thank you very much, Chief Kweki and Chief Opoke and every other person on the platform tonight. Thank you for the guidance. I've taken question 1 to 10 in preparation for the upcoming March 21st exam. So please, you can kindly call me back for clarifications, and the place that are great to me too, I would love to learn more so that we can all trash this thing at once. So going to the first question, which I'm going to read out now. A 54-year-old African American man with a history of hypertension and hypercholesterolemia undergoes a treadmill exercise test using the standard Bruce protocol. It stops at 11 minutes 14 seconds because of fatigue. At a peak heart rate of 152 beats per minute and peak systolic blood pressure of 200 millimeters of mercury. The diastolic blood pressure declines by 5 millimeters of mercury during exercise. During recovery, the systolic blood pressure decreases to 15 millimeters of mercury below its pre-exercise pressure. There are no ischemic changes on the ECG during and or after exercise. Which of the following is correct? Option A, is peak systolic blood pressure during exercise exceed that normally observed. Option B, the change in diastolic blood pressure during exercise is indicative of significant coronary artery disease. Option C, this test is non-diagnostic owing to an inadequate peak heart rate. Option D, these results are consistent with a low prognostic risk of a coronary event. And option A, the post-exercise reduction in systolic blood pressure is suggestive of severe coronary artery disease. So looking at this question, I'm just going to look at the options and try and explain with what I've studied so far, what the possible answer can be. So in exercise stress test, one of the things that we should pay attention to is the systolic blood pressure response, the maximum predicted heart rate of such people, and then another thing that we need to pay attention to is the ST changes while the patient is is doing the procedure. We should also know the stage that the patient can no longer tolerate or is fatigued, or you have to stop the procedure. And we also need to keep at the back of our mind the indication for the exercise test. So for the option A, it says is peak systolic blood pressure during exercise exceed that normally observed. For that option, that is wrong. When you are doing normally during exercise, you expect that there should be a higher response in the systolic blood pressure, and this has been put at a range of 160 to 200 millimeters of mercury. This patient had a response of 200 millimeters of mercury, which is actually very good during an exercise stress test. In fact, these patients are having less than 120, or if they are hypotensive during the stress test, you are worried that there might be some other severe coronary artery disease or multivessel disease, and in such patient, that the hypertension points to the fact that there is severe coronary artery disease in such people. So normally there should be an increase in systolic blood pressure up to 160 to 200 millimeters of mercury. So that option is false. The change in diastolic blood pressure during exercise is indicative of significant coronary artery disease. No, diastolic blood pressure does not have any predictive value when we are doing the exercise stress test. It doesn't predict anything. So that option is also false. Option C, this test is non-diagnostic owing to an inadequate peak. Sorry, something came on the screen. Okay. Option C, this test is non-diagnostic owing to an inadequate peak heart rate. This is also false. I talked about the maximum predicted heart rate, which is equal to 220 minus the age of the patient. That's what it's supposed to be. That's what the maximum predicted heart rate is. And in this particular patient, his heart rate during the exercise went to as high as 152 beats per minute. His MPHR 220 minus his age, which is 54, give us 166 beats per minute. So to calculate the maximum predictive heart rate in this patient, you need to divide what the MPHR is by the heart rate that is gotten during the exercise. And it is expected that if you have an heart rate of 85% or more, that it is diagnostic and adequate in exercise stress ECG. So that is also false. Then the option E, sorry, let me go to E. It says that the post-exercise reduction in systolic blood pressure. Thank you, Dr. Kweke. The post-exercise reduction in systolic pressure is suggested severe coronary artery disease. No, this reduction is just about 15% of mercury. Most there will be a sharp reduction in the blood pressure either during or after the procedure, that you will be getting an hypotensive range for the patient. And this is commonly seen when they have multivessel disease or maybe a left main coronary artery disease. So that is when they have reduction in systolic blood pressure. But what these patients have is not up to that, which is actually okay. Then option D says these results are considered with a low prognostic risk of a coronary event, which is actually true because these patients have a normal response, a normal systolic blood pressure response. The MPHR, when it was calculated, was also about 92%, which is actually adequate response in this particular patient during the exercise stress ECG. So the correct answer is option D. Thank you so much. Please ask for clarifications and contributions.
I think you can go ahead. This wait, we should avoid it. We can save some time. Whoever has question can interrupt. As you finished what you have done, come on to the next one.
Okay.
Yeah, as you just finished, to the next one. So whoever has question can ask, or you can drop it on the chat. You can just interrupt shortly. So we don't, I know in the past we have maintained this little break that takes about 30 seconds. If you put it all together, it's almost like 20 minutes.
Okay. Thank you, Chief Kweke. I'll move to the second question 2.
Also, please, there's no protocol. You don't need to raise your hand. You can just unmute your mic and contribute. Not with, sometimes you might be thinking you need to follow your protocol. There's no first person, no second person, please. And please help. If you know more about it, any of these questions, just contribute so that it must not be question. It can be your vast knowledge, what you've read, and how to make it clearer. Thank you.
Thank you very much, Chief. Thank you for that comment. Please, if you know more about this exercise stress test, please let us talk. So I go to
okay.
Okay.
Okay. Good evening, everyone. Okay, I just dropped a comment in the chat section. I was thinking the Duke's treadmill score contributes to the low prognostic risk. You know, that contributes to option D actually being more definitive. That's just what I was thinking. Because if you calculate the Duke's treadmill score, the patient score is 11, which is obviously very low.
Yes.
So that's my suggestion. Yeah.
Thank you so much. Okay, so I'll quickly move to question 2. Which of the following statements regarding the second heart sound is true? Option A, earlier closure of the pulmonic valve with inspiration results in physiologic splitting of S2. Option B, right bundle branch block results in widened splitting of S2. Option C, paradoxical splitting of S2 is the auscultatory hallmark of an ostium secundum atrial septal defect. Option D, fixed splitting of S2 is expected in patients with a right ventricular electrically spaced reading. Option E, severe pulmonary valvular stenosis is associated with a loud P2. So I'll just quickly say that the second heart sound has two components. That's the aortic component and the pulmonic component. The aortic component is early, where the P part is actually later. And during inspiration, what happens is that there is increased filling of the right side of the heart. And this is what caused the normal physiologic response of the splitting between the aortic component and the pulmonic component of the second heart sound. However, so if there is anything that increases, that further increases the opening, the closure rather of the right-sided valve, the pulmonic valve, there will be a delay in closure, and that one will widen the normal splitting of the S2. I don't know whether that is clear. So in this particular question, we are talking about the second heart sound. Earlier failure of the pulmonic valve with inspiration results in physiologic splitting of S2. Okay. I hope I'm not mixing it up and down. Okay, let me just leave that option for now. What I know is that in right bundle branch block, in this particular option, what happened is that there's a right bundle branch block, so there is a delay in the closure of the pulmonic valve, and this leads to a wide splitting of the S2. That means the timing between the aortic closure and the pulmonic closure actually widened. So that option is actually correct. Also, in atrial septal defect, what happened in atrial septal defect is that there is a fixed splitting of the second heart sound in this group of people. And this is because of the increase, in blood flow through both chambers, and then there will be a delay in the closure of the pulmonic valve, of the right-sided pulmonic valve. I don't know whether I'm getting that right. Please, I need help. I need help with that. Okay. But let me finish the options, please. Then in option D, fixed splitting of S2 is affected in patient with a right ventricularly paced reading. No, there will not be fixed splitting in them. There will be a paradoxical splitting in this set of people. Then option E, in severe pulmonic valvular stenosis, there is loud P2. When there is stenosis across any valve, what happens is that the degree of excursion of the valve to close is the closure of the valves that gives us the heart sound. But when there is stenosis, this excursion of the leaflet is, so when it's reduced, the sound that you'll be hearing won't be loud. It will rather be a soft heart sound. So I don't think that one is also the correct answer. So for here, I think B is the correct answer for this question. I don't know, please, clarifications and contributions.
Yes, Dr. Neonju, you are right. B is the, good evening, everyone. B is the correct answer, but what you are also explaining is correct, just a little more clarification. Normally, when there's this physiological splitting of S2, which is caused by when you inspire the volume in right ventricle. So usually there should be a delay between the P component and the aortic component. That's the pulmonic component and the aortic component. So when we now have a right bundle branch block, for instance, we now have a wide split. Then disease conditions like the atrial septal defect, secondum to be precise, will give a fixed split. You call it fixed wide split, whichever is a fixed split that you have. Whereas in left bundle branch block, we'll know that since there is a block, so what is activated first will now be the left side. the right side rather, since there's a block on the right side. So it will now be a reverse split for things that will give an LBB. Also, as we know, pacing, when you pace the right side of the guy, gives an LBB pattern. So that will also give a split. So that makes the other two options wrong. Then the early closure of the pulmonic valve, that's option A, will be wrong, because what we expect is the late closure of the pulmonic valve with inspiration is what gives the split normally.
Okay.
I think that's just clarification. Yeah.
Thank you very much. There's any other contribution
Okay.
before we move?
Good evening. I don't know if I'm audible.
Yes, please.
Okay. For the ASD and fixed split, as you have explained, you know the split normally is because of it varies with respiration. When you breathe in, there's blood flows into the right side of the heart, with delays closure of the pulmonic, and there's early closure of the aortic valve. That's what causes the normal physiologic splits. But in ASD, because it is a pathological movement, pathological defects, so it does not, that split in ASD does not vary with respiration. That's why it is called a fixed split, because it does not give flow of blood from the left side to the right side of the heart. In ASD, it does not vary with respiration. So that's why it's called a fixed split, unlike the others that varies with respiration. So those are just normal physiologic split. So that's just my contribution on that. Thank you.
Thank you very much, sir. Any other comments, please? Okay, Dr. Opopi, question 3. So question 3 goes thus: a state-of-the-art blood test has been developed for the rapid, non-invasive diagnosis of coronary artery disease. The assay has a sensitivity of 90% and specificity of 90% for the detection of at least one coronary stenosis of greater than 70%. Okay. In which of the following scenarios is the blood test likely to be of most value to the clinician? Option A, a 29-year-old man with exertional chest pain who has no cardiac risk factor. Option B, a 41-year-old asymptomatic premenopausal woman. Option C, a 78-year-old diabetic woman with exertional chest pain who underwent 2 vessel coronary stenting 6 weeks ago. Option D, a 62-year-old man with exertional chest pain who has hypertension, dyslipidemia, and a 2-pack per day smoking history. Option E, a 68-year-old man with chest discomfort at rest, accompanied by 2 mm of ST segment depression in the inferior leads on the ECG. Which of the following scenarios is the blood test likely to be of most value to the clinician? Okay, thank you very much. So for option A, 39-year-old man with exertional chest pain who has no cardiac risk factor. Well, I don't think that this test will benefit this man because he doesn't have any risk factor, although he has exertional chest pain. Well, let me leave that option for now. Option B, a 41-year-old asymptomatic premenopausal woman. Patient is asymptomatic. I don't think that it will be beneficial in this woman too. Patient is asymptomatic, has no reason to be involved in a non-invasive diagnosis of coronary artery disease. And she's 41 years old. Okay, premenopausal. Okay, option C, a 78-year-old diabetic woman with exertional chest pain who underwent 2 vessel coronary stenting 6 weeks ago. For this particular woman who has just done a 2 vessel coronary stenting 6 weeks ago, it's actually better to go and, well, with my limited knowledge, I won't know, but I think it's actually better to go and look at this woman stent again. Is it like she's not taking an anticoagulant very well, or whatever has been given to her to take? Is there a restenosis of the stent? I think that would be a better option for this patient. So it will be invasive. Option D is a 62-year-old man with exertional chest pain who has hypertension, dyslipidemia, and a 2-pack per day smoking history. For this man has risk factors, and it might be the most suitable. But let me go to option E. Option E is a 68-year-old man with chest discomfort at rest, accompanied by ECG changes in the inferior lead on the ECG. So I think this is an emergency. It will be invasive. But for the 62-year-old man who has chest pain on exertion and has many risk factors, this might be a test that will be suitable for him. For the 29-year-old man with exertional chest pain who has no cardiac risk factors, I'm not sure that that's the best test for him, but I'm open to contribution and clarification. So yeah, I think that the correct answer is option D. Thank you. Please, contribution and clarification. Hello?
Yes, Dr. Adeyanju. Yes, we can hear you. Yes, the answer is D actually. But might just be that the reasons might just maybe what we should try and trash out. They're talking about sensitivity and specificity here. If we are not certain that a patient has enough risk, you understand, and we are subjecting the patient to that test, we will have a lot of maybe false positives. However, if we are certain also that the patient has all the risk, almost the risk is high, and we are suggesting sublecting or maybe putting the patient on the treadmill or maybe on the test, for instance. Now, we're talking about troponins here, I think. We will be getting a lot of falsely negative. So what I feel makes option E not the answer is that we have enough reason to already ascertain that this patient has an obstruction. So there's no point doing that. Just go straight and, you understand, relieve the obstruction. That's what I feel about E. And also about I think is this C now, the one that had previous and was stented 6 weeks ago. So we know that already the patient has risk of a wrist stenosis, for instance. So why the best thing is just to go and relieve whatever the obstruction is there. Then for the 29-year-old with exertional chest pain who has no cardiac risk factors, it's not likely. So the risk there is low. So also the 41-year-old asymptomatic premenopausal, why do we want to do that? The risk is already so low. So we do this test for those that have intermediate risk, which D falls into. He has yes, he has this pain, which looks like the angina pain, and he has the risk factors. So we want to be sure if there's actually an obstruction. So we suggest the patients. That's what I feel. So it's those that have the intermediate risk that we should subject, so that we would rule out or will not give unnecessarily maybe falsely positive or false negative results in the instance. Thank you.
Thank you very much, Dr.
Just to add to that, Dr. Rumade, that's a very beautiful contribution. Am I very clear?
Yes, Chief, sir.
Am I clear?
Yes, you are clear, sir.
Sorry, am I clear?
We can hear you, sir. You're audible.
Okay, so yeah, so that's a very good explanation. Just to add one or two things to it, I think the idea here is to make a diagnosis of STEMI for a patient with this new test. Okay, and usually STEMI is straightforward elevation, but NSTEMI is usually the problem. So there are 3 different categories. Usually you want to categorize them with your troponin. So depending on the value you are using, so you can see the group that are low risk, intermediate risk, and high risk, like she said. The high risk, you can easily just say they have high risk, like the example she talked about in that very patient that have everything in place. Then the low risk, You can also just read them out like the number one question. 29-year-old without any good risk factor, just has exertional chest pain. So that's low risk. You can just say this is likely a non-cardiac problem. But where we have a whole lot of problem is the intermediate risk. You want to catch a lot of patients in that intermediate risk who will eventually have STEMI and who may not have STEMI. You don't want to miss the one that we have, and you don't want to necessarily capture the one that doesn't have. That's usually where the problem is, which she also said it. Look at the D patient. Okay, so these are the kind of patients you really want a test that is very sensitive to be able to pick the one that have STEMI. So usually in practice, these are the kind of patients you want to look at some other factors to be able to define whether they have STEMI or not. So you look at, is there a history of diabetes? Diabetes become a very strong risk factor, even though it's intermediate. Number two, is there strong history of premature family heart disease? Number three, is there any previous angio in the past where we know the anatomy of the coronary arteries, where it had had a mild disease that had probably progressed to a severe disease? So these are, is there this significant smoking? So these are other things you are looking at to be able to pick the one that may have disease. But if you're looking through this thing and you're not still satisfied, these are the kind of patient you want to go for with non-invasive test. And I say that's a bit very sensitive, up to 90%, and specific up to 90%. In other words, they can tell you the people among this intermediate risk up to 90% of the time that have the disease. On the other hand, they can also tell you up to 90% of the time people that do not have the disease. Okay, so I didn't hear everything, but I remember this question. I thought I should just pop this in. Thank you.
Thank you so much, Chief Kweke.
Dr. Adeyanju, some persons are complaining they can't see the screen.
They can't see the screen? Oh.
Yeah, I also can't see, actually.
Thank you, Doc. So sorry. Hold on. Dr. Kweke, thank you so much for that beautiful clarification. I don't know if we can. Can you see the screen now? Those I can't see, please.
We can't see you. Sorry, Chief. You have to reshare, sir, or whoever is sharing.
Okay, Dr. Uzoke, please can you unshare it?
All right, let me do that quickly.
Okay, all right.
How are you?
Thank you so much, Dr. Kweke. Thank you.
How you doing now?
He's a he's a professor. Hello. Leader, sir. Welcome our previous one time now president on the platform. Thank you so much, leader, sir. Thank you again, Dr.
Thank you.
All right. Thank you, Dr. Kweke, for that beautiful clarification. Trying to share the screen. Anybody else? All right, thank you. So the test appears to have a moderate sensitivity and specificity. So with respect to what Kweke has said, that's very, very classical. We move forward. Uzoke, are you having challenges with respect to sharing, or should I share from my end?
Chivokop, you can try and share from your end now. If they say they are not seeing my screen, then.
All right, let me give you the try and see.
Yes, sir. Yes, sir.
Okay. I mean, please just try it again. I'm having this. Okay, wait. I think I'm getting there now. Just go ahead. Let's try yours. Try yours again. Let's see, please.
All right, sir. All right, sir. Please. Yeah.
Hello, can you see my screen? I'm sharing my own.
Very well, yes. Yes.
Okay, so the presenter can continue. I can be scrolling for her.
Oh, that's lovely. Can you zoom it into the question, please?
Okay. I don't understand the zoom in now. Is it just scrolling?
Okay,
this? Is it okay like this?
Okay. Yes, it is. It is. Dr. Adeyanju, you can tap on your screen to get it closer to you. Perfect.
Okay,
Perfect. 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 So you have a laptop, Dr. Christiana?
Yeah.
Okay, so maybe subsequently you would help us to record if there's nobody.
Okay.
All right. Thank you so much.
And after recording, you're supposed to drop them on our platform on the Telegram group so that everybody can have access.
Okay. You will teach me how to record though. I don't think I can see record on my screen.
No
okay, I'll show you.
Can you close the side panel?
We'll show you tomorrow in the hospital. So.
Okay, thank you.
So, can you close the side panel to make it bigger?
Okay, thank you so much, Dr. Alabu, for coming to our rescue. Thank you to all our chiefs too. We are on number 4. Question 4.
Sorry, please. I don't know if we all understood this particular question. Is it common stuff that Prof usually sets in the exam? Sometimes he will just bring values and be playing around it, because we have very proficient statisticians and gurus in this particular question. If you know you understand it and you just let us so that I can go over it, please. This is a common question that Prof plays around. Objectives.
So I hope, like we said, just to recap. So the idea is that you're looking for a test that could pick those people that are intermediate risk for STEMI. Because some of those people at intermediate risk may not have STEMI. They may eventually go back to the one that are low risk, which likely no cardiac causes. Some of those people that are intermediate risk, they may eventually move to the high risk and they have significant disease that you need to intervene. So you don't want to miss them, and then you don't want to overdiagnose so that you not over do intervention for people that doesn't need it. So you need a test that is highly sensitive In other words, you can pick the problem if the problem is there. A test that is highly sensitive, in other words, the test will show negative when the people do not have the disease. So, and those are the category of patients that are listed in the option. If you check them all through, you will see the one that are low risk, you see the one that are high risk. So high risk patients, you don't have to do any further non-invasive or screening tests. You just have to take them to cath lab and intervene. Low risk patients, you don't have to really do anything. Just look for a non-cardiac cause. By the time you're thinking that it may be NSTEMI, meaning you've classified the patient to be intermediate risk. But again, you are not 100% sure. So you're probably thinking that this patient may not, this patient may. But you don't want to miss the one that have it, and you don't want to intervene on the one that do not have it. So you need a very good test that have good sensitivity and good specificity. I hope it helped.
Yeah, thank you so much. So Dr. Alagba, I don't know if you can go back to that option so that we can now see the spectrum of risk. And you see the spectrum of risk. And then if you see the test was supposed to pick out 70% stenosis of one coronary vessel, which most likely at this stage might just give you an NSTEMI. So if you see like option A is a 29-year-old man, a 29-year-old man with exertional chest pain who has no cardiac risk factor. That's a low risk. That's a low risk.
Like
please, can we mute?
She may not start.
Who is this person? Ojo.
I'm muting them already. Thank you, sir. So you can see the 29-year-old man with exertional chest pain who has no cardiac risk factor. That's a low risk. 41-year-old asymptomatic premenopausal woman. That one didn't even fall into anyone. So, but a 78-year-old diabetic with exertional chest pain who underwent 2 vessel coronary stents 6 weeks ago, that's already an high-risk patient. So there will be no need for this test for the patient. If you go to now the E option, which is a 68-year-old man with chest discomfort at rest, complaint accompanied by 2 millimeters of ST segment depression in the inferior lip, is already high risk. So that's why this test for a 70% stenosis will most likely be ideal for an intermediate risk patient, which is a 62-year-old man with exertional chest pain who has hypertension, dyslipidemia, and a 2-pack here of smoking history. And that's basically what almost everything that I can find on this. If there's further clarification or any, I remember a question that Prof asked us in this last. Yes. So he will just play around with values and he will just come up. The statistics he will bring will be applied, not there will definitely be a statistic question. So we can dwell on this if you need more verification. Thank you, quickly. Thank you.
Yeah, if you look at C and D, you can observe that in C, this guy had angio 6 weeks ago, and then had stented to 2 of the vessels. And now she's come back with exertional chest pain again. Compared to D, like Dr. Kopi have said, out of this C and D, which of them will you want to take to the cath lab, or which of them you think that, may have a significant disease to be more value to a clinician? Is this D? Because this C, you've already done an intervention. So this pain may just be coming from maybe residual disease. This pain may just be coming from, usually sometimes, if they have taken the anticoagulant properly, you don't expect stent thrombosis. Okay, except that happen if they have not been taking the antiplatelets as prescribed. So I think that's give a little light. Thank you.
All right. So in the absence of any other clarification, we can go to question 4. Thank you so much, Dr. Alagba.
Sorry, Chief, thank you so much for your contributions. And for the low risk,
are we supposed to do like cardiac enzyme for them? Are we supposed to do cardiac enzyme for them for the low risk patients, like
low risk.
patients that are low risk? What are we supposed to do?
So if they have low risk, usually like that gentleman that you see and that lady premenopausal, they likely no cardiac reason for the pain. Okay. But again, there are some low risk that eventually will crop into intermediate risk. So that's why they say that STEMI is usually the problem when it comes to diagnosis. So that kind of patient, 29 years old, exertional chest pain, no cardiac risk factor, you have to look for no cardiac cause. I'm sure you will have also done an ECG. ECG will have been normal. And if you're worried as a clinician, usually as part of the investigation, the package, when things are working, anybody that comes with chest pain, you just do routine troponin. And the troponin is less than normal. We use a lower cutoff of 14 here. So if it's less than 14, okay, ECG is normal, no cardiac risk is stuff with that age, that rules out STEMI. So it's not a group of patients you want to be rushing for. But as per protocol in many centers, anyone with chest pain anyway, they just do troponin. As they're just entering the emergency, you will have done troponin because of chest pain. So you'll have also seen troponin result that's normal. ECG is also a routine for anyone that have chest pain. ECG is normal. A young person, no cardiac risk factor. Look for other non-cardiac cause for the chest pain.
Okay.
It doesn't mean that if it's not STEMI, it can also be pericarditis, remember. It can also be myocarditis, remember. It can also be pulmonary embolism. So it doesn't have to be. When we say no cardiac, likely we're referring to is not due to coronary artery disease.
Okay, so that means in summary, patients with low risk would have an ECG done and maybe alongside a cardiac enzyme. Then people with intermediate would have a non-invasive procedure done, like maybe CT coronary, a non-invasive diagnosis of coronary artery disease. Then for those who are high risk, will now have the invasive ones, right? Then probably undergo stenting or coronary bypass. I hope I'm in the right track. I don't know.
So it sounds like that, like a well-structured statement that intermediate risk, non-invasive, high risk, you intervene. But in practice, it's not always like that. Okay, because everything depends on the clinician that is trying to assess the patient. This patient, that other one, if you can go to that question 3. Question 3. Some of these questions are also dependent on the doctor they're saying. So this is a 62-year-old man with exertional chest pain, has hypertension, diabetes, 2-pack per day or smoking history. Then you go further to do ECG and their ECG changes. Trophy is mildly elevated with mild rise. Why would you want to do non-invasive? You will just take the patient to cath lab and have an idea of the coronaries. In fact, in US, they almost put everybody through cath lab anyway. So the point I'm trying to make here is that, yes, intermediate risk as per guideline recommendation, non-invasive assessment. But sometimes once you look at, you individualize your patient. That's my point I'm trying to make. You will also have to individualize the patient, because some of these things, they overlap. So it's difficult for you to see on a clear cut that this is the intermediate risk. So you look at this C patient, only had diabetes and chest pain, yet he had 2 vessel disease. you know. So what would you have said? Someone with diabetes and chest pain, intermediate risk, I will not do anything. Let me go and do non-invasive first. So non-invasive test is for ruling out coronary artery disease. The idea of non-invasive test, you want to rule out coronary artery disease. If you see the patient, even though he's in intermediate risk, and you think that based on your experience, based on your practice, you see that this patient, even though you're intermediate risk, like this gentle woman, sorry, this lady, not gentle woman, this lady, a 78-year-old diabetic. Once you hear diabetic, you're a bit more concerned because they tend to have diffuse coronary artery disease because of diffuse atherosclerosis. So even though they fall within an intermediate risk kind of, is it a candidate that you want to just take to the cath lab and study the coronaries? At 78 years of age is there, chest space exertional. And of course, this lady had 2 vessel disease. So over time in practice, you pick your experience. But like I said, what you said seems to sound like a protocol. Intermediate risk, non-invasive assessment to rule in and rule out. High risk, intervention. Low risk, likely non-cardiac cause. Look for non-cardiac reason. And generally speaking, anyone that comes to emergency with chest pain will have done an ECG, will have done troponin. So by the time you are seeing all these patients, there's an ECG, there's a troponin. So this A patient, apart from the chest pain and no cardiac risk factor, there's also an ECG looking at you that's normal. There's troponin result looking at you that's also normal. So you just say, no, this look for another pain other than cardiac reason.
Thank you.
Thank you, Kweki. And sorry, Dr. Florence, there is a presentation on ACS from A to Z by Dr. Sori Conte around 12th of September last year. It's on our Telegram page. Please, you can also refer it. It's both from scratch to guideline-directed management. Others too, please, you can get to the Telegram pages there. It's about 3 hours presentation by Dr. Conte.
Okay, thank you, Chief.
Thank you so much for the elaborate clarification, Chief Koike. Thank you so much. I don't know if I can continue now.
You have
Please
to
go ahead. Go ahead.
Thank you so much.
Keep the ground running.
Yes, question 4. A murmur is suspected during routine examination of an 18-year-old asymptomatic college student at the second left intercostal space, close to the sternum. The murmur is crescendo-decrescendo, is present throughout systole and diastole, and peaks simultaneously with S2. It does not change with position or rotation of the head. Which of the following best describe this murmur? Option A is a continuous murmur. Yes, I agree that it's a continuous murmur. Most likely a venous commonly heard in adolescents. Option B, this is a continuous murmur resulting from mixed aortic valve disease. Option C, this is a continuous murmur due to a congenital shunt, likely a patent ductus arteriosus. Option D, continuous murmurs of this type can only be congenital. Murmurs due to acquired arteriovenous connections are purely systolic. I don't know, is there an option here? Okay, no option here. Hello, Dr. Alagbe. Please kindly go back to question 4. Okay, so I will start from option D. Continuous murmur of this type can only be congenital. So I would like us to know that continuous murmur can either be congenital or acquired. And if this is the case, that option is the fact that they say that it can only be congenital. That is actually false. and they are not, they can either, the continuous murmur means that they can be heard both in systole and diastole, which is what is written in this question already. So this is false. Option C, this is a continuous murmur due to a congenital shunt, likely a patent ductus atterosus. This is likely correct because in PDA, in fact, what they call the murmur, I think they call it a machinery murmur, is continuous throughout systole and diastole and is crescendo decrescendo. That's actually classical for PDA. Then for option B, this is a continuous murmur resulting from mixed aortic valve disease. In mixed valvular disease, I don't think that they will really have a continuous murmur depending on which disease that is predominant, whether it's a stenosis or regurgitation. I don't think that they will have a continuous murmur there. Then option A, this is a continuous murmur, most likely a venous commonly heard in adolescents. It's true. For venous murmur, an example is cervical murmur, which is actually heard in young children and adolescents, but they are just they are elderly they are heard in elderly people. But the thing about this venous murmur is that it can actually change with position and most times rotation of the head. Anything that increases the venous blood flow, maybe like during the state of pregnancy or thyrotoxicosis, or anything that just increases flow to the chambers of the heart will actually increase the intensity of venous murmurs. And an example is the cervical venous murmur. So for this particular option, I think option C is the correct answer, which is the PDA. And it refers to be classical for PDA. Thank you. Please comment and clarifications.
Good evening. I don't know if I'm audible.
Yes, please.
Yes. Thank you very much. I think the right option will be option C. That option B, another reason why it's false is that this murmur it's heard on the second left intercostal space. For mixed aortic valve disease, you expect the murmur to be at the aortic area, which is on the right. So as opposed to this question, is the murmur is heard on the left. So I also make option B to be false. So that's it look like the most correct option there. Thank you.
Thank you very much. Please kindly unmute to add to our knowledge, contribute and clarify, please. Okay. In the absence of further comment, please can we move on to question 5? Okay, thank you very much. Unequal upper extremity arterial pulsation will be unlikely in which of the following disorders? At the back of our mind, what we should first ask is that what are the things that causes unequal upper limb extremity? Yes, I mean, in our daily practice, we must come across any aortic dissection, then anything that affects the distribution of blood, maybe a coarctation, or if there is anything affecting the subclavian artery, all those will actually cause a difference in the upper extremity arterial pulsation. So for this option, O will actually have a difference in arterial pulsation. Takayasu, yes, that's a big vessel disease, which also cause a difference in arterial pulsation. Supravalvular aortic stenosis, yes, I also think that one, supravalvular, yes, I think that one should also cause a difference in the pulsation. Subclavian artery atherosclerosis, yes, that will also cause a difference in the pulsation. So the most unlikely one in this option is option E. And I think that would be the correct answer. Thank you. Any contributions, please?
Hello, good evening. Please, thank you so much, ma. My question is, why do you think supravalvular is false, but subvalvular is true?
Thank you very much for the question. Apart from using MCQ sense for this thing, we know that the option is actually between C and A. For supravalvular, I think where the valve is, once there is blood flowing through the supravalvular aortic stenosis area, there is the likelihood that, I mean, with what I read, there is a likelihood that there will be selective streaming of the arterial jet towards the right arm, making pressures to be unequal in the extremities, and they call the phenomenon a co-anadose phenomenon. That in the supravalvular, because of the stenosis around that side, but for subvalvular, they said it is absent because they don't have the same physiology. That was the little explanation that I got when I went through the internet. Thank you, but I'm open if there are further explanation.
No, you got it. That was I wanted to bring to light, that is actually the phenomenon that occurs, that results in that selective streaming is actually what causes the inequality. So you are in order, ma. Thank you so much.
Thank you, Chief Ajayi. Please, any other clarification or questions? Okay, let's hit the ground running. Question 6, ma. Dr. Alagbe. Thank you very much. A 58-year-old woman with metastatic breast cancer presents with exertional dyspnea and is found to have a large circumferential pericardial effusion, diagonal venous distension, and hypotension. Which of the following echocardiography sign is likely present? Yeah, they're talking about the cardiac tamponade, which is actually classical from the question. So option A, it said collapse of the right ventricle throughout systole. Option B, exaggerated decrease in tricuspid inflow velocity during inspiration. Option C, exaggerated decrease in mitral inflow velocity during inspiration. Option D, exaggerated increase in left ventricular outflow tract velocity during inspiration. Option E, markedly increased E/A ratio of the transmitral Doppler velocity profile. So I will start with option A. For option A, collapse of the right ventricle actually occurs in cardiac tamponade, but we must remember that this occurs in diastole, and it is in early diastole, not systole. And this is said to be sensitive in diagnosis of cardiac tamponade, as opposed to when you say a collapse of the right atrium. So for cardiac tamponade, there is increased sensitivity on echocardiography when you are seeing right ventricle, not atrium, during early diastole. Option B, exaggerated decrease in tricuspid inflow velocity during inspiration. I think that this would be an exaggerated increase in tricuspid inflow velocity during inspiration. So this might make this one also false. Then for option C, exaggerated decrease in mitral inflow velocity during inspiration. Yes, I think this is actually correct because during cardiac tamponade, at a particular point, there is ventricular interdependence. This is when there is almost equality in the pressure in the right and the left side of the ventricles. And when this occurs, during the mitral inflow velocity, during the mitral inflow velocity, there is a decrease in that velocity. Option D, exaggerated increase in left ventricular outflow tract velocity during, no, this will be during expiration, not inspiration. Then option E, markedly increase E/A ratio of the transmitral Doppler velocity profile. Markedly increase. Yes, in cardiac tamponade, there's an increase in E/A ratio, but I don't think it's markedly increase. This markedly increase in E/A ratio is actually more fitting for constrictive pericarditis cardiac tamponade. Thank you very much. I don't know whether there are questions or contributions. Please, there is an echo. Please, clarifications, contributions. Hello, please, am I audible?
Yes, ma, you are audible, ma.
You are
Let us-
audible.
If there isn't any further question on this, then we may proceed if there are questions.
Thank you very much, Kazamas. Question 7, please.
Hello, ma. Good evening, ma.
Good evening, sir.
Yes, please, the option A, collapse of the right ventricle throughout C2. I guess, is that the one? Yes, that is the question bar. Sorry. I didn't get it. What did you explain about the sensitivity?
Okay, I'll come over that again. Thank you very much. In cardiac tamponade, the pressure from the fluid outside the heart, I mean within the pericardium, the pericardial effusion, the pressure from it is actually pushing the ventricles and the right atrium at that particular point in time. So what I explained is that in cardiac tamponade, when you say right ventricular collapse, it is more sensitive for cardiac tamponade compared to when you say right atrial collapse. A right atrial collapse is telling that there is pressure, increased pressure, but it's not sensitive for cardiac tamponade.
All right. So, sorry, I think there's a little mix up in that. This thing. Yes, it's actually talking. That place is actually talking about the specificity. That the right ventricular collapse is actually more specific than right atrial collapse. Right atrial collapse is more sensitive, while right ventricular collapse is more specific to tamponade. And the diastolic collapse, right ventricular outflow diastolic collapse. Most author believe that it's mid-diastole that the collapse occur. There's one of these echocardiologists that gave us lecture in US, one of their seminars. Most of the thing that he did there was mid-diastolic collapse, rather than mid to late.
Okay, I came across mid, but I saw more of early than mid. And then for the other one, thank you for the correction. The R is a sensitive marker for increased pericardial pressure, but it is not, but the RV is specific for cardiac tamponade.
Yes, thank you.
Thank you very much.
And the reason is just straightforward. Why is specific? If there's a collapse in right atrium and the right ventricle, which of them will affect cardiac output?
Is the right ventricle.
Is the right ventricle. So that's the reason why it's more of an indicator. When we use the word specific, it means that if it is not there, likely there is no cardiac tamponade, even though you're having a collapse on the right atrium.
Yes.
So that's just the ideology, because if there's a problem there, collapsing, it's going to affect the cardiac output to the pulmonary circulation and then to the right heart, and then systemic circulation will be affected, especially if compensatory mechanism is impaired. Remember that in that instance, the concept of interventricular dependence also comes in, where the IV septum shift more towards the left and reduce the LV cavity and then reduce stroke volume. Okay, so that's the concept behind it. Thank you.
But to clarify, with respect, Amadou Samaila, I think it's early diastolic collapse, not if you even follow the diastolic phase of cardiac cycle, at the mid to late, the intraventricular pressure is already increasing. Which of them do you think will have more effect? The intrapericardial pressure having more effect on the intracardiac pressure when blood is already filling from mid to late? It's basically early diastolic collapse of the right ventricle. I think maybe, I don't know what you have to say about it. I don't think it's mid to late.
I think I agree with you. Using common sense, I think I agree with you. We'll do more research on that.
Actually, it's not common sense. It's early diastolic collapse, actually. Thank you.
Anyway, whether early or late or
I agree with you. I agree with you.
What is important is that you have to ECG-gate the patient. That's the only way you can define some of these things. I understand that these are part of the theory, which is fine. But in practice, you're going to be looking at your ECG gating in DAS to be able to check if there's any collapse. So whatever early or mid, whatever.
Yeah, the reason is because for exam purposes, please, is early diastolic collapse. And
Another reason why it's early is that in early diastole, how many percentage of blood gets into the heart?
Yes, that was what I was saying. You understand? So it's and then also the sensitivity, the right atrium is a low pressure chamber. So any intrapericardial pressure can have effect on that. So you wouldn't say it's basically specific for cardiac tamponade. So even when you have indentation of the right atrium, you wouldn't say that's basically an onset of cardiac tamponade. So it's just sensitive. Thank you for the clarification.
Exactly. Thank you very much. That was the explanation I found. Thank you.
All right. God bless. Take care.
Thank you so much, Chief Kweke, Dr. Somali, and Dr. Okupe. Please, can I continue? Question 7. Which of the following statements about pulsus paradoxus is correct? So basically for pulsus paradoxus, I just want to explain so that because time is fast spent. Of pulsus paradoxus, what is happening is that there's an exaggeration of the normal tendency for arterial pulse strength to fall with inspiration, and this usually between 8 and 10 millimeters of mercury. So when patients breathe in, there is a fall in this systolic blood pressure, and this is usually measured with by the patient bedside. I should think that a catheterization can also be done, but I did not read deeply to actually look into that. But I'm happy that Chief Kweke is there to actually verify that. So for option A, inspiration is in normal individual results in a decline of systolic blood pressure of up to 18 millimeters of mercury. That's false. Option B, accurate determination of pulsus paradoxus requires intra-arterial pressure measurement. I don't think that's correct. I don't think so, but I stand to be corrected. Option C, pulsus paradoxus is unlikely to be present in patients with advanced aortic rotation, even in the presence of tamponade? I'm not sure. Option D, pulsus paradoxus is common in patients with hypertrophic cardiomyopathy. I don't think that is correct. I think the answer is either between B and C, but I am not very sure. So please, I need help here. Thank you. In patients with advanced aortic rotation. Chief Kweki, sir.
Okay, so I would go with C as the correct one. You know, the concept of pulsus paradoxus is also a fallout from what we just discussed earlier on.
Yes. Yes.
So usually, based on respiratophasic variation, there is variation in the early flow, mitral flow, or tricuspid flow, as the case may be. Okay, and there are also some form of interventricular dependence, such that because of the increased flow during changes in respiration, there's bulging of the IV septum into the left. Okay, but again, this is not usually exaggerated, but in case of where you have cardiac tamponade, where you have pericardial effusion, okay, because of that pressure, the heart is not able to, the right side is not able to dilate with the pericardium in diastole. So most of the pressure will push through the IV septum into the left ventricle, reducing the cavity such that there is 4 in stroke volume and there's 4 in blood pressure, more systolic blood pressure, more than 10. Usually it's less than 10. So once it's less than 10, there is no pulsus paradoxus, but because of the pressure now, is reducing the cavity of the left ventricle, leading to reduction in stroke volume. So that leads to reduction in the systolic blood pressure of more than 10. So I just explained the echo changes, okay, that happen in a patient that have paradoxus, pulsus paradoxus, which usually you can do with your blood pressure. You don't need intra-arterial pressure measurement. You can do it with the sphygmomanometer. So that makes B not to be correct. Okay, and again, you can also measure the variation between in respiratory or expiratory changes. Okay, the E velocity through the mitral valve and E velocity through the tricuspid valve. You can check their flow changes, okay, the E velocity. That variation can also give you an indices of what is going on in terms of exaggerated interventricular dependence. So that's what happened. But in a case where you have advanced aortic regurgitation, okay, where you have so much volume in the left ventricle, okay, so that pressure in the left ventricle can compensate for the pressure as a result of the cardiac tamponade or pericardial effusion, such that interventricular dependence is not exaggerated.
I guess that's. Thank you so much, Chief.
Okay, just to add to that, when we get to presentation on valvular heart diseases, and we get to aortic valvular heart diseases, you remember the classification. I think you've been with us at Jamila, of advanced aortic regurgitation with respect to the diastolic pressure. So if the diastolic pressure, yes, if it's increasing, it will blunt the effects of the interventricular dependence and then maintain the end diastolic volume that will contribute to the systolic blood pressure, such that there will be no drop as much as the 8 to 10 millimeter of mercury we observe, which is also the reason why pulsus paradoxus is not common with hypertrophic cardiomyopathy, because the interventricular pressure is already high. So the effect of tamponade on the interventricular dependence will not be there. It will be blunted out because of the end diastolic pressure that is increasing both of these cases. in C and D. So the blood pressure drop will not be that marked.
Yes.
All right.
Thank you so much. Question 8. If a 7-year-old man with a history of hypertension and elevated LDL cholesterol presents to the emergency room with the acute onset of substernal chest pressure, dyspnea, and diaphoresis, his blood pressure is 158/96 millimeter of mercury, and the heart rate is 92 beats per minute. Physical examination reveals clear lung fields and no cardiac gallops or murmurs. The ECG shows sinus rhythm with a prominent R wave in lead V2, and then 0.5 mm of ST elevation in lead and 2 mm of horizontal ST depression in V1 to V3. So the following will be diagnostically useful to plan a course of action. Okay, definitely, they're trying to give us a picture of STEMI here, but we are just to localize which arterial territory. So for option A, repeat the ECG with right-sided precordial leads. B, repeat the ECG with V7 to V9 leads. Option C, await results of serum cardiac biomarkers. Option D, obtain a chest computed tomography to assess for pulmonary embolism. Okay, so I think option D is out. I don't think this is a pulmonary embolism. I think waiting for serum cardiac biomarkers when we already have something classical might be more injurious to the patient than going to the cath lab immediately. For option, so that means we have between option A and B. For option B, repeat the ECG with V7 to V9 leads. And for this, I think this the part affected in this myocardial infarction is actually the posterior arterial territory. And for those, because we don't usually do the posterior leads, we will be watching out for reciprocal changes in V1 to V3, which is what this patient already have. If we are thinking more of a right inferior MI, the blood pressure here does not even fit into it. And then for this particular group of people, we want to do a right-sided precordial lead, which we also don't usually do. So for this particular question, I think the correct option is option B. I think it's that territory that is affected here, which we will see depression in V1 to V3, and also the prominent R, which is suggestive of prominent R is also suggestive of a posterior arterial territory affectation. Thank you very much. I don't know whether there are additional comments.
Well, thank you, Dr. Adeyanju. Yes, I agree with you. B should be the correct option here. But what I want us to take note of is why not A? Do you understand? So what we're actually looking for, it's between A and B. So we should be able to know when we are looking at the posterior leads and when we should look at the right-sided precordial leads, because both will give changes in the anterior V1, V2, in the anterior leads. That's what I'm trying to say. And the morphology of the of the QRS complexes in the anterior leads will be different for either way. I'm not sure or I'm sure you understand what I'm trying to say, Dr. Adeyanju. So looking for the precordial leads, when we have a prominent or a dominant R wave, it's showing that it's like a mirror image of what we are to see if it were to be an ST segment elevation. So by that, you will think more of a posterior infarction, posterior affectation. If on the precordial leads, maybe the V2, V3, we don't have a prominent R wave, if there's no R wave, if it's still the QS, do you understand? And it's not, the R waves are not prominent. So you know it's not a mirror image. So it will be more for the right-sided infarction. And by that, you look for the classic ST segment elevation in RV4.
Yes.
So that's just what I want. Yes. So when we see prominent R wave, we should know that is the posterior that is affected, because both V1, V2, V3, the anterior leads is for both. So is whatever we see is what will make us know if it's we are to trade the right ventricular infarction or we are looking at the posterior. Also, the trick, I think there is even a catch here, if you remember, Dr. Adeyanju. These there was one time we were discussing this lead 3, that if the ST segment elevation is more in V2, in lead 2 than in lead 3, when we were considering infarction. So this is sort of confusing. But what I would like to say about that lead 3, because they just told us is 0.5 mm, although 0.5 mm is not significant, or is not like a what's the right word to use now? It's not consecutive leads. It's only one lead. So we'll just take that like a pinch of salt. But I think they just put that there, could be like a confusion to let us think if the ST segment elevation is greater in one of leads, 2 or 3 might be infarction. So I think that's just the confusing part there. So we should maybe just try and read more on how we'll know if they're actually talking about right side infarction or a posterior infarction. Thank you.
Thank you for your contribution. Is any other contribution?
Just to add to what you had said, that's actually fantastic. Thank you so much. Any other person want to make a comment? Dr. Sumaila? You can go ahead first. I can talk later.
All right, thank you. Thank you for the opportunity. The one thing which I want us to also take note there is the arterial supply of those that places, right coronary artery, both the posterior wall, the inferior wall, and the right ventricular wall. So it depends on the part that is actually occluded. If the occlusion occur early at the proxima, most of the time it can combine all of them, and then it will give a picture that there will be posterior wall infarction, inferior affectation, and even the right ventricular affectation. So, but concerning the leads, the lead 3 and lead 2, what is usually said is that you suspect a right ventricular infarction if the ST segment elevation in lead 3 is more than lead 2, even without using any right-sided lead. That will prompt you to use a right-sided lead to confirm what you are seeing. Thank you very much.
Yes, I agree with this. When it's higher in 3 than in 2, then even the blood pressure in this particular
yes, they usually present with hypotension, right ventricular wall infarction.
Yes. Yes. Thank you so much.
Thank you, sir.
Please further comment.
Sorry, quickly, you're going to speak now. I just want them to just
okay.
Again.
Prof, go ahead, sir.
If they can just help me focus the question again. It seems the person focusing the question has changed the direction. Okay, quickly, can go ahead.
Okay. So if we look to that question, if the patient has ECG already tells you that their ST segment elevation depression in V1 to V3. That is the classic things you need to look at first. There's depression in the anterior leads or anteroceptor leads 1 to 3. So once you see that, the first thing you want to ask yourself, are we having just NSTEMI involving the anterior or something more? So the next thing you look at again, they gave us the information. One of them, look at that prominent arrow wave in lead V2. Remember that the posterior, you could have the PDA or the posterolateral branch to the ventricle. The branch could come from the ROCA, or the branch could come from the LC circumflex. So if you're having posterior MI, which I think everybody agree with that because of the involvement of V1, ST segment depression in V1 to V3, with a prominent arrow wave in V2, that gives an idea that whatever is going on is as a result of the circumflex is probably the dominant artery is giving rise to the PDA, which is infected and which supply the posterior, which is infected. So that's the reason why you are seeing a prominent arrow wave. And in fact, when they constructed the question, they now gave us 0.5 mm SC segment elevation in lead 3. Lead 3 is a right-sided lead. Ideally, if you were thinking of a posterior MI, okay, you're supposed to have reciprocal changes in inferior leads. If it's a right-sided dominant artery, giving rise to the PDA. So for us to have S6.5 segment elevation in the 3, which is not significant, and then you're having a prominent arrow wave in V2. So this tells you that this patient have posterior MI involving likely the PDA, and the circumflex is what is giving branch to the PDA. That's the reason why arrow wave is becoming prominent in V2. And if you look at the right, the 3 is not significant. So the problem is not as a result of infection of the ROCA, rather as a result of a problem in the circumflex, which likely is a left-sided dominant coronary artery giving rise to the PDA. So I'm sure we agree that you will have to do your posterior lead 7, that's V7 to V8. Sometimes these are really easy to do, just tuck it there. And most time, in fact, in an emergency where you have things that are working, before the patient gets to you, as a cardiologist, they will have done everything just right before you. They reverse all the leads, label them 7, 8, and 9, so you can make your decision. Thank you.
Thank you so much, sir. Prof, sir.
Prof, you can add anything, there's more.
I just wanted to clarify something. I guess Dr. Molade, right? And was saying something about lead 3 was more than lead 2 or something, and that it was like a distraction. I just wanted to understand what the comment is about. You're comparing lead 3 and lead 2. Because that was why I wanted us to focus on this question to see if the comment was on this question.
Yes, sir, it was on this question, and Dr. What is his name now? Dr. Amodu has also made comment on that, because I said we are supposed to tease out. Hello, Chief. Am I audible?
Yes, thank you. Finish first.
Okay, that we are supposed to maybe try to trace between options A and B. So I was just trying to say that we should know when, maybe we read further when it should be maybe option A or option B. But because although the explanation that Dr. Kweke has given me now thinking back, another understanding of this question. However, when I saw the question and I saw elevation on the 3, my mind flashed back to when we have right-sided infarction, in which we'll have changes to on the anterior leads. but there will not be not necessarily be prominent R wave in on the anterior leads. So it will be S wave instead, and would in that wise we will have to treat the right-sided leads, specifically that's the RV4. And according to what Dr. Amontu has said, that in lead 3, the ST elevation in lead 3 will be more than ST elevation in lead 2, which will point towards a right-sided infarction. So I now felt putting lead 3 here and putting ST segment elevation, that it might just, looking at it just as a glance, reading through fast in an exam might be like a distraction. So that was what I was trying to say, that what we actually need.
Well done.
Hello, Chief. That was what I was trying to say, just trying to differentiate between.
Well done, sir. The comment I made was just it's not specifically in this exact scenario. It's not specifically for this exact question.
I know we are saying the same thing, Chief. It's for right ventricular infarction.
Am I audible?
You are, sir.
Hello?
I can hear you, sir.
Am I audible?
Yes, both of you are audible. But I think the thing that Prof is asking us is about the lead 2 and lead 3. Dr. Mola said that the height of ST in lead 2 is more than lead 3. And you said that the height of ST elevation in lead 3 is more than lead 2. I think that's just what Prof wants to hear.
Okay, thank you very much.
Yes, sir.
Well, so I appreciate Chief Wiki. Thanks for the help. It has been very fantastic. It's just to further buttress the thing Dr. Wiki said, that anytime you see a prominent R wave in V1 or V2 coinciding with the ST segment depression, okay, so there are two things you'll have to think about. You should think about, one, a right ventricular hypertrophy, or two, a posterior MI. Okay, so I'm sure we've all seen posterior MI before. So it's just to further emphasize that R wave you are seeing, if it's an MI, that R wave you are seeing is a Q wave, actually, because the reciprocal change, okay? And the ST segment depression you are seeing is actually ST segment elevation. You get it? So that means it has already Q'd. So it becomes a Q wave and an ST segment elevation. Now, so the next thing you want to look at is the inferior lead, which is the AVF and lead 3. So you would actually see some sign of ST segment elevation in them. And so the reason why you will see that is because, as Professor Koike have said, the PDA is the guy that is affected here. So if the posterior descending artery is involved, you should see inferior lead involved, because the PDA supplies the inferior wall of the heart, okay? The posterior MI you are seeing is not from RCA, as Dr. Momodu said. It's not from RCA. So posterior MI is coming from the circumflex artery, because that's the artery that goes to the back. Okay, so when you say posterior MI, circumflex artery, and when you now see an inferior ST segment elevation, it means that the PDA, that's the posterior descending artery, is coming from the circumflex. So it makes this patient a left dominant patient. You get that? But if you see only inferior MI, meaning that ST segment elevation in the 3 and AVF, maybe involving the 2 sometimes, and you don't see the involvement of V1 or V1 to V3, and probably you now have lateral leads involved with ST segment depression. So in the pure inferior MI, you should think more of RCA, okay? But anytime you have a posterior MI, and you should think more of circumflex. When you now have a posterior MI involving also the inferior wall, you should think that the circumflex is the guy giving the PDA, okay? Or there's some involvement of the PDA sha. But a pure posterior MI is from the circumflex artery. So anytime you're doing ECG localization with the coronary anatomy, Posterior is circumflex, inferior is RCA, anterior anterolateral is LED. It's important to your ECG assessment. Okay, I think Dr. Okopi still has that ECG localization. He posted it to us sometimes.
Yes, thank you. I'm still here, sir.
You still have that?
Thank you so much, Prof. Yes, sir. Thank you. Thank you so much, Prof. Thank you. Thank you so much, Dr. Kwek. I think we did a presentation on this around late September. It's on the Telegram page, very elaborate. Please, when we're done, you can go and refer to it to help you localize some of this. Thank you, Prof. It's there on the Telegram page, but I will check for the PowerPoint presentation and put it back on general. Thank you, sir.
Thank you very much, Prof. Very, very explicit, sir. Thank you, sir. You're a blessing, sir. Thank you. I don't know. Please, can we move on to the next question if there are no further comments? Question 9, please, Dr. Alagbe. Okay, so for question 9, which of the following combinations does not have the potential for significant pharmacologic interaction? Option A, simvastatin and erythromycin. Option B, sildenafil and nitroglycerin. Option C, pravastatin and ketoconazole. Option D, cyclosporin and St. John's wort. Option E, digoxin and verapamil. I must confess that with this question, I was actually confused. The only thing, I was thinking that everything will have an effect. So what I tried to do was to look at like option B. I know that both of them will affect the post vasodilatation and then they will affect the blood pressure. So I know that that one will have significant interaction. I know in the past I used to hear that statins and ketoconazole and their metabolism in the liver, maybe a PY450. So this question, I was not sure of the answer, so I had to go and check the answer. And the correct option they picked was C. But how they navigated to get there, I won't be able to say. So I don't know if there are people that can assist us in the class or if you just read out the answer. Thank you.
Yeah, can I make a comment briefly?
Yes, please.
All right. I think drug interactions essentially most times has to do with their metabolism. Most of the drugs are metabolized in the liver by cytochrome P450. Some drugs causes the upregulation of cytochrome P450. And in such case, if you give other drugs that are metabolized by cytochrome P450, you have to give a higher dose. Otherwise, it will be as if you're underdosing the patient because the prior drug has already limited the elevation of cytochrome P450. Now, some other drugs causes the reduction in the concentration of cytochrome P450. That's downregulation of that cytochrome P450. In such case, if you give drug that is not in their normal doses that are metabolized by P450, it will cause toxicity. So if upregulation and the normal dosing causes a reduction in the effectivity of the drug, whereas in the downregulation and the normal dosing causes increased toxicity. From the much I had seen before now, drugs like erythromycin, clarithromycin, ketoconazole causes the downregulation of P450. Azithromycin, including azithromycin, but azithromycin doesn't cause the downregulation. Let us take note of that. You remember that the azithromycin is equally part of the macrolides. Then drugs that are metabolized by P450 will include atorvastatin, simvastatin, lovastatin, cyclosporin. Pravastatin is not metabolized by P450. Now, St. John's wort increases P450 activity, that is upregulation of P450 activity. Verapamil decreases the excretion of digoxin. Consequently, it will cause the toxicity of digoxin. Phosphodiesterase inhibitors potentiate the toxicity of nitroglycerin. So in that case, we have the answer here as C, because there we have pravastatin. We recall that pravastatin is not metabolized by P450. And even though that ketoconazole will cause the downregulation of P450, but pravastatin is not metabolized by P450. Thank you.
Thank you so much, Chief, sir. Well, I thank you. I understand what you've explained. So if you meet this exam now, is it just pravastatin or all statins? Because yes, the ketoconazole, erythromycin, all those ones, yes. So is it just pravastatin that is not metabolized by the P450, or there are other? Thank you.
I think in the exam setting, they will be interested in such drugs that are outliers. What do I mean? Azithromycin is the macrolide that does not cause the downregulation of P450.
Okay, sir.
Yes. Then in the statins, pravastatin is not metabolized by P450.
Okay.
I think these are the only interests I'll have in mind if I'm going in, when I'm going in. But the other statins actually are metabolized by P450.
Okay. Thank you so much. Please, further comments and contributions.
Okay, good evening and well done so far. Let me just add that among the statins, pravastatin and rosuvastatin are water soluble, while the others are lipid soluble. So this is another factor, largely excreted unchanged. So they do not go through the cytochrome P450. So they're kind of a subgroup, shall we say, of water-soluble statins, while Atova, Rosuva, and most of the others are lipid-soluble or lipophilic, and are under the and are metabolized by cytochrome P450. So their water and lipid solubility appears to influence that. Thank you.
Sorry, you said pravastatin and what drug is water soluble?
Rosuvastatin.
Rosuvastatin. Thank you very much.
Yes, you're welcome. Thank you.
Yeah, thank you so much.
I missed the other one you mentioned. Sorry for pravastatin and what?
Rosuvastatin. Yeah, rosuvastatin.
All right, thank you.
Thank you so much. Please, any other further comments? Okay, question 10, please. It will be question 10. It will be reasonable and safe to order a treadmill exercise stress test for a patient with which of the following conditions? Option A, symptomatic hypertrophic obstructive cardiomyopathy. Option B, advanced aortic stenosis. Option C, acute myocarditis. Option D, abdominal aortic aneurysm with transverse diameter of 5.5 cm. Option E, unstable angina. Okay, for option A, patient is already symptomatic, so I don't think that ordering a treadmill exercise stress test will be of any further advantage in this group of patients. For option B too, patient is already advanced aortic stenosis, so I believe that patient will already be symptomatic. And I don't know what an additional treadmill exercise stress test would do to change the treatment in this patient or line of management. Acute myocarditis, I think this is a no-no. That one is not going to add anything to the treatment of this patient. Abdominal aortic aneurysm with transverse diameter of 5.5 cm. This might be a possibility. If they've written an aortic aneurysm, I might have said that this is a no-no, but an abdominal aortic aneurysm is likely a possibility. Unstable angina is also a possibility. So please, I'm between D and E. I will need help here too. Thank you.
Hello,
Please,
can you hear me?
class that can help. Thank you. Good
Hello,
evening,
can
sir.
you hear me?
Hello, Dr. Ojo.
Good evening. Good evening, ma'am.
Yes,
Yes,
sir.
I just want to comment on that option D, that is aortic dissection. That's a contraindication to a treadmill exercise test, not aortic aneurysm. For a patient with unstable angina, already have some ischemic changes going on, so you want to be careful in those kind of patients. So I think it's option D.
Okay, thank you very much. Please, further comments and clarifications. Hello.
Yeah, thank you.
Yes, please.
Okay. I think if it's question, notice that apart from option D, every one of them are among the absolute contraindications to treadmill exercise stress test. Symptomatic hypertrophic obstructive cardiomyopathy is an absolute contraindication. Likewise, advanced aortic stenosis, acute myocarditis, and unstable angina.
Yes.
Abdominal aortic aneurysm with transverse diameter of 5.5 cm is quite debatable. So I think among all of them, this is the one that actually stands out that we can consider exercise stress test for them. Thank you.
Thank you, Dr. Francis.
Let's hit the ground running. Adeyanju is pretty straightforward, no time.
Okay, so the answer here is option D. I just went to check the answer and they said it's D. Thank you very much. This marks the end of my questions. Thank you so much, Prof, Chief Kweki, Chief Okope, and everyone that contributed to having a better understanding of these questions. Thank you. The next discussant is Dr. Orimolade. Thank you all.
Yes, thank you. Thank you, Dr. Adeyanju. So my questions, I will be taking us through questions 11 to 20, but I would need assistants' contributions so that we can have a robust understanding and discussion of this section. So question 11 says, a 42-year-old woman with hypertension and dyslipidemia underwent a one-day rest stress exercise myocardial perfusion SPECT study with technetium-99 imaging to evaluate symptoms of atypical chest pain. Her resting ECG showed left ventricular hypertrophy. She exercised for 12 minutes, 30 seconds on the standard cruise protocol and attained a peak rate of 155 beats per minute. She developed a brief, sharp parasternal chest pain during the test that resolved quickly during recovery. Based on the imaging,
images in figure 1.1, which of the following statements is correct? So please, can we go to figure 1.1? So this is a SPECT scan. Don't know much about SPECT scan, but the little I know is that the SPECT scan is used to evaluate for functionality as well as the perfusion of the myocardium, and is used in this case of this patient that has an atypical chest pain, so as to be able to know the functioning parts of the myocardium, if there is any part of the myocardium that is not functioning. So ideally, as we can see from this picture, the one done at rest and also the one done during stress or following stress. So it should actually all be bright, should I call it yellow? When at rest, if you look at the first, we have 3 columns on our left, or 3, let me say, pictures on our left. So the first column at rest and during stress, we could see that at the, these are the, what part? This posterior, at the anterior parts, you can see that is actually dark, like the, not as bright and yellow, or is it orange that we call it, like the remaining, and it's occurring both at rest and also at during stress. The second column is emphasizing that same alteration of the yellowish color. I don't know if the person projecting can help me with the cursor at the apex, and is showing also at rest and during stress, while the lower section 2, okay, we have just minimal, but like almost everything, both at rest and at stress, there are no affected areas there. So, so now let's do, that's what I can explain about this, my understanding, my little understanding. So please, let's go to the question. So ideally, any parts in which we see that is not, the attenuation is not there, that the parts that are probably not functional, so to speak, and it's not supposed, we are supposed to see it following stress. At rest, if the rest ECG is actually okay, we should have the attenuation at rest, and following exercise brings out the parts that are not well perfused. So option A says the SPECT myocardial perfusion images are diagnostic of transmural myocardial scar in the distribution of mid to left anterior descending coronary artery. Mid left anterior descending coronary artery, they said transmural, okay, I'll come back to that. Let me just, then the B is the anterior wall defect on the SPECT images is likely an artifact due to breast tissue attenuation. I'll come back to that too. Telenium 201 would have been a better choice of radiotracer to image this patient. Well, I checked, that would be false because the technetium 99 is actually better, with a better resolution than thallium 201. That one is of a lower quality than the technetium that was used. So that would be a false. The gated SPECT imaging cannot differentiate attenuated artifacts from a true perfusion defect. That would be false. It should actually, it's actually always able to tell artifacts from a true perfusion problem. Then E, a transmural scar is associated with reduced wall motion, but normal wall thickening on gated SPECT image, that would be false, because ideally okay, let me say, when we have a scar, the thickening, the walls will actually, the thickening of the wall will be reduced when there's a scar, compared to when there is no scar. So when there are no scars, the thickening are actually is normal. But when there is a scar, the thickening of the myocardium is reduced, because ideally, following an infarction, we expect a transmural affectation, and when scar tissues are formed, there will be thinning, which eventually will lead to the sequelae that we know of DCM and the failure, as the case may be. So that makes that a false. Then now back to, actually B is the correct answer, because both at rest as well as at following exercise, the consistency of the areas that were not well attenuated was the same, which means that usually is likely going to be an active fat from the patient is a female, from breast tissue. That's what I'll pick as the answer, which is B. Then what makes A false? They said the SPECT myocardial perfusion images are diagnostic of transmural myocardial scar in the distribution. That's a false, because it will have been true if, because the arterial territory, which is the left anterior descending, that supplies the apex, and the lateral and the apex, which is what was shown. But it's a false because it was present both at rest and at during following exercise. I think I need clarifications and contribution, but that's my understanding of SPECT. Thank you. And okay, Dr. Adeyanju has dropped a comment. It depends on the affected area, severity, pattern of, yes. Yes, yes, that's what it's saying. I agree. Oh, okay, or you are answering another question. Okay, I think she's responding to the
Yes.
So, okay, thank you. Please, any comments, clarification, so that to help our understanding.
Okay, well done, doctor. What I understand, the little I've read about it, Sha, is that when there is an infarction on SPEC, both at rest and with stress, you will see a defect. Do you understand? Then
okay,
if it's only ischemia, you're going to see a defect with stress. You won't see defects with rest. But if you look at this question, right, the patient was fine. Then the patient had a sharp chest pain before the patient recovered. So from this, I think the patient has an ischemia. Do you understand?
Okay.
Because left to me, the patient was fine, then had a sharp pain, then recovered quickly. So it's likely an ischemia. That's what I think. So that's why I agree with your B, that what we are seeing both with rest and stress is not an infarction from the question. So it's likely that there's an attenuation from the breast, an impact from the breast.
Okay, I got that.
Well done.
Thank you.
Yeah.
Thank you. Please, more clarification, or we should move on.
I think it's, both of you have quite explained it. I don't know if Prof will want to say more on this or quickly before we go to the next. I think Prof did extensive work. Prof, thank you, sir.
She will go to
I may go back to the picture so that Prof can explain for that. The picture.
Dr. Alagbe, you mentioned something that patient had pain at stress, then at relieved at rest. And that's why I want to just really get that explanation again.
Okay, I said from the question what I understand. I know that, okay, when you look at spec, when you see a defect both at rest and with stress, it's likely an infarction. Then when you see a defect with stress alone, it's likely an ischemia.
I'm following you.
Okay. So for this patient, if it was an infarction, no, I felt from the question, I felt it was an ischemia because the patient had a sudden pain and then the patient recovered quickly. So I think it's an ischemia.
So because so you're basing the assessment of this imaging based on the symptoms. The patient had a chest pain that resolved immediately, so it's an ischemia, right?
Yes, that's what I feel.
Oh, so that means you're saying it's never going to be possible to get an infarct.
No, sir, it's like it can also be an infarct. But what I'm saying is that based on the patient's symptoms and then based on what we are seeing from the stress and rest,
no, because
I feel we're seeing this. Okay, sorry.
Maybe
I don't have a better understanding then.
No, it's like I'm not sure you would be able to use the symptoms to make a judgment on a spec analysis, on a spec test. You can't use the symptoms to judge. Okay? So you can't say, oh, he had a chest pain that resolved within 30 seconds and then it's an ischemia. It's not an infarct. No. I don't think that's possible with this. So just remember that this nuclear imaging is a dynamic imaging. That's one important thing. So a patient might have had an old infarct or ischemia. That is what the purpose of this thing is. If you're actually using to determine viability of a tissue, if you do go ahead to revascularize a tissue or you don't bother revascularizing a tissue. Those are the importance of actually doing a nuclear imaging. Hope you get that, man. So it's not based on symptoms at all. So if you see a patient before you that even has had an infarct before or an ischemia before, it doesn't matter the symptoms at this time. It's about you want to assess if you review the patient and you think this patient has an ischemic disease and you've done an angiogram, either a CT angiogram or invasive angiogram, and you've seen lesions. You now want to say, okay, should I go ahead to revascularize or not? That is where a dynamic imaging helps. So that is the importance of actually doing a nuclear testing. So it's not based on the symptom of duration of pain or not. I want you to get that information very clear. That's the purpose why you send the patient for imaging, nuclear imaging. Patient, you want to vascularize, should I go ahead or not? And there are different types of imaging you can do. So you have the nuclear imaging and you have the MRI, which you can do. And you can also do the fractional flow reserve. They are all form of kind of dynamic testing. So in this doing nuclear imaging now, so we have the PET scan or you have the SPECT scan. Okay, so one is kind of superior to the other. So a PET scan is kind of more superior than a SPECT scan, simply because it gets rid of artifacts. Okay, and the duration of the radionuclide agents you give. You know, this radionuclide agent is being metabolized in the blood system, right? So the duration of the agent staying in the blood system is longer with a PET than a SPECT. And also the image acquisition is faster with a PET than a SPECT. So in the exam, they can actually either bring a PET image or a SPECT image. They will look alike because they are nuclear imaging. Okay, but one has lesser kind of artifacts and so has better interpretation than the other. And PET is far like 10 times more expensive than the SPECT. You get, so we should have just those information at the background. So as you rightly said, you will get the images both at stress and at rest. The same way for either you're doing a SPECT or a PET, it's the same way. You get the images both at stress and at rest, and they'll put the images side by side so that you can compare. That means the section, the cuts. So if it's a short axis cut, a horizontal long axis cut, they'll put the images side by side so that you can assess the coronary anatomy as you're assessing that chamber of the heart. So as you rightly said, if there's a filling defect at rest and at stress, then you can say is either is an artifact, probably an attenuation from in a SPECT, but if it's a PET, you won't be talking about attenuation, okay? Or it is a scar, okay? So meaning that at rest, there was no perfusion, and at stress, there was no perfusion, okay? So what the agent does, so they usually, so apart from radionuclide imaging you give, during the stress, they give adenosine, okay? And we all know the effect of adenosine is to improve coronary perfusion, right? So we give the adenosine very fast, and with the radionuclide imaging that's already given, okay? So you can now see that same coronary anatomy, is the perfusion better or not, okay? So if the perfusion is better with stress, okay, it tells you that that is a viable tissue, okay? But if the perfusion does not improve, that means that even if you vasodilate or revascularize, the tissue is already dead. So revascularization is not going to make any sense. So I want to be sure you've gotten this information.
Yes, sir.
Okay, great. So if you look at this image, especially in the quadrant to your left-hand side, okay, and in the last two quadrants, that will be the fifth row, and the fifth and the sixth row. So it's a long axis view, okay? So you can see horizontal long axis. So you can see that above, like you are doing a plaques view, okay? So you can see above, you can see that the color there looks faded, right? In the tissue above. Sorry, it's because I'm not the one in control of the slide. So
Alagbe, can you take the cursor to the sixth row, on your lower left hand corner? Come down a bit. Come down a bit. Lower left. Lower left. Come to your left.
Okay.
Yeah, correct.
Okay, yeah. So you can see that's the sixth row, right? You can see where you are pointing at. You can see the fading of the color. It's fading out. Why the lower chamber, the lower layer, you can see is well opacified, right? Okay. So if you compare it with the row 5, you can see the same segment is still faded at rest, so at stress also. Okay. So it tells you that it's either is a scar, or it is an attenuation. So attenuation, so that is why we usually want to avoid using a SPECT. You rather go for a PET. So that's a problem with a spec. So now, the reason why you now know that is an attenuation is that if you now go to the second column, where you are seeing end diastolic frame, you can see that almost everything there looks as if has filling defects. All the segments you get compared to the end systolic frame. Okay, so that's some parts that will tell you that there's attenuation problem here. You get, but technically you use the end diastolic frame and the end systolic frame to see the chamber size. So another thing that I failed to mention is that when you're doing a nuclear imaging, you also determine the chamber or the lumen size, the chamber. If it is dilated, okay, at rest, both at end systolic and end diastolic, then you can actually tell that, yes, it's an infarcted chamber. That means there's no contracting. You get, so it also tells you the viability problem. So if the chambers are as chamber inside the nuclear imaging, or the chamber inside the nuclear imaging, yeah, those chamber, that's inside the circle. So that's the chamber. Okay. If it is dilated both at end diastole and at end systole, it tells you that chamber is not contracted. So that means that the tissue around that is not viable. Because if you give the nuclear imaging at stress, there's increased perfusion, so there should be better contraction, Abby. So if you are not achieving good contraction, meaning that in the stress period is both dilated, so that tells you that these tissues are not viable. But the most important part of viability testing tells you that there should be a filling defect both at rest and at stress, okay? But if the filling defect resolves with stress, it tells you that that tissue is viable. Hope I've been able to do one tiny sense. So do we have any questions?
Thank you so much, Prof. Very clear. Any question, please? Is there any question from anyone, please, before Dr. Okorie? Thank you so much, Prof. It seems there's no question from anyone. Alison, I don't know if you got it clearly, please.
Yes, very clear. It's more than a tiny sense, like you said. It's a whole lot of an explanation.
Yeah,
I'm very
Prof
grateful.
is well.
Yes.
Thank you so much, Prof. We're so grateful. Thank you. Thank you, sir.
Thank you, sir. Yes, so I move on to the next question, which is question 12. Says an 82-year-old man with a history of coronary artery disease underwent coronary artery bypass graft surgery 6 years ago. He presents to the emergency department with right upper quadrant abdominal pain and anorexia. His medication include aspirin, metoprolol, succinate, and atorvastatin. Physical examination. Am I reading the same question? Yes. Physical examination, laboratory assessment, and abdominal ultrasound confirmed the diagnosis of acute cholecystitis. The patient has normal vital signs and his pain is improved with analgesia. The cardiovascular consultation service is called to perform operative. Sorry, please, what edition is this one, sir?
It's 12th.
12th. Okay.
Yes.
Risk assessment prior to, I didn't actually answer this question. risk assessment prior to cholecystectomy. The patient lives with his spouse in a 2-floor home. He does not routinely exercise, but is able to walk up 1 flight of stairs to his bedroom each night without chest pain or shortness of breath. He denies recent current angina or dyspnea on exertion. There has been no orthopnea, paroxysmal nocturnal dyspnea, or peripheral edema. The cardiovascular examination is normal, and its ECG in the emergency room is unchanged from a prior tracing 4 months earlier. What is the next appropriate step? Okay, A says recommend percutaneous cholecystostomy rather than laparoscopic or open cholecystectomy due to the high risk of surgery. B says recommend vasodilator stress myocardial perfusion imaging prior to surgery. C, recommend that he proceeds with surgery with no further cardiac testing. D, stop metoprolol succinate prior to surgery. Okay, so looking at the options, well, I didn't actually solve this question. So stop metoprolol succinate prior to surgery. I don't think that would be a correct answer. Then recommend that he proceed with surgery with no further cardiac testing. Then recommend vasodilator stress myocardial perfusion imaging prior to surgery. Okay, recommend percutaneous. Okay, if you are doing a perfusion test, like we just learned, you want to see maybe previous car or the parts that are functional, so the functionality of the myocardium. Okay, recommend percutaneous cholecystectomy rather than laparoscopic or open cholecystectomy due to high risk. Well, I don't know. The option is between A and C. Sorry, it's between A and B for me. So I might be needing help here. Sorry, please, I will need contributions here. I think I'm using another edition, so I didn't solve this question.
So this is a guideline directed question. So maybe somebody should just read the answer from the book since it's guideline.
Yeah, sorry, I didn't solve this question. I'm so sorry about that. I think I'm using another edition.
Dr. Cyril, can you read the guideline from the answer? Question 12.
All right, sir. All right, sir. This patient with acute cholecystitis is being evaluated for intraperitoneal intermediate risk surgery, which carries a cardiac risk of cardiac death or non-fatal myocardial infarction of 1% to 1 to 5%. He has no clinical evidence of a recent acute coronary syndrome and can achieve at least 4 metabolic equivalents, that is, climbing a stair of a flight of stairs regularly without cardiopulmonary symptoms. For such a patient, current guidelines recommend that no additional cardiac testing is required prior to surgery. For patients with poor or unknown functional capacity, Pharmacologic stress testing is recommended if the results will impact decision-making. For patients with ischemic heart disease, undertaking intermediate or high-risk surgery who can achieve greater than 4 METs, guidelines conclude that initiation of titrated low-dose beta blocker regimen may be considered prior to surgery, commencing at least 1 day prior to the procedure. This patient is already taking metoprolol succinate, which should be continued in the perioperative period. That's what I said, sir.
Okay, thank you. So the answer is D. Oh, sorry. The answer is what from this thing? Appropriate step. And so stop is not the correct answer. Please, what's the correct answer, sir? Hello, Chief.
Oh, sorry, you didn't hear me. Sorry, so I don't know. I have off my microphone. I was saying the answer is C. That he should recommend that he proceed with surgery with no further cardiac testing since he was already on beta blocker.
Okay.
Thank you.
Okay, thank you. Thank you so much. I don't know if we need clarifications from anyone or contribution.
I think the question is straightforward. I didn't meet the initial aspect, but this is a patient whose functionality, cardiac-wise, is fine. Is it the patient that did the cabbage bypass surgery, right?
Yes.
Yeah, I did bypass surgery. So I've apparently had significant coronary artery disease that warranted bypass surgery. And post-surgery, it's been fine as per cardiac rehabilitation, been able to work up some flight of stair, had no problem, no cardiac symptoms. So as I go for the surgery and there's no problem. So that's what's the, usually, you want to assess cardiac status for patients that are going for surgery. But already had bypass surgery, we usually has a very fantastic outcome in terms of prolonging mortality and all that. So don't need to do any other thing to be able to assess how good the cardiac status.
All right, Chief. Thank you so much, Dr. Okweke. I don't know if I can proceed.
Please hit the ground running. Go ahead.
Yes. Question 13 says a 56-year-old asymptomatic man with a history of hypertension and cigarette smoking is referred for an exercise treadmill test. After 7 minutes on the standard PRUS protocol, is noted to have 1 mm of flat ST segment depression in leads 2, 3, and AVF. He stops exercising at 9 minutes because of leg fatigue and breathlessness. The peak heart rate is 85% of the maximum predicted for his age. The ST segment returned to baseline by 1 minute into recovery. Which of the following statements is correct? So A, this test is conclusive for severe stenosis of the proximal right coronary artery. B, it's going to go to B. B says, is risk of death due to acute myocardial infarction during the next year is greater than 50%. C says you should proceed directly to coronary angiography. D, the test predicts a 25% risk of cardiac events over the next 5 years, most likely the development of angina. E, this is likely a false positive test. So let me start from E, so we don't keep going back and forth. This is likely a false positive test, and that's a wrong answer, actually, because the patient has all the risk and has intermediate risk from previous explanations that we have. So the treadmill test that he did, he was able to achieve 85% of the predicted, and he developed signs necessitating symptoms necessitating stopping of the test. So it's not actually a false positive. It would be a true positive in this instance. So D states the test predicts a 25% risk of cardiac events over the next 5 years, most likely the development of angina. I'll come back to that. C, you should proceed directly to coronary angiography. Will be false, because this patient's coronary angiography will mean that patient has classic angina symptoms, and probably doing an ECG have ST segment elevation. But this patient actually is asymptomatic, so proceeding for an invasive procedure would not actually be now, because the test we are doing is to predict his future risk, actually. Then that will make C false. B, is risk of death due to an acute myocardial infarction during the next 1 year is greater than 50%. That's too high of a rate. And the test prediction that we do is not actually 1 year. I think is D actually be the correct answer, which is 5 years risk of about 25% risk of cardiac events with a positive stress test result. And option A says the test is, please can we go to option A? Option A said this test is conclusive for severe stenosis of proximal right coronary artery. Yes, the arterial territory from the ECG is actually showing that it's from the problem is likely from the right coronary artery, but we really cannot say we can't diagnose severe stenosis from a treadmill test. We need an invasive to be able to diagnose if it's severe or not. So I think the correct option there should be option D. I don't know if there are comments, clarification, and contributions, please.
Sorry, what did you say about C? About option C?
Option C says it should proceed directly to coronary angiography. The patient is asymptomatic, has come for a predictive, has come for a test. It has intermediate risk and be subjected into tests. So the proceeding directly to invasive angiography in an asymptomatic patient will not be a correct option, sir. So I think the answer should be D, which the test has helped us to predict. But B might not be correct because 1 year and greater than 50% is high. I don't think that's correct. So the option should be D. Do you have any comment on that, sir? Okay. Okay, I don't know if I can move on to question 14 if there are no comments.
You can move. There's no time. Move.
Thank you. Question 14 says, in which of the following scenarios do ST segment depression during standard exercise testing increase the diagnostic probability of significant coronary artery disease? In which of the following scenarios do ST segment depression during standard exercise testing increases the diagnostic probability of
Yeah, again, Dr. Dianju and Dr. Uzoki. Network, I guess.
Looks like network.
Network. Sorry, Molade. I think it's a network.
Okay. I think any of you can just help her to read by waiting for her, so that we can save some time.
Okay.
I just wish she'd be hearing us because her mic is not moving at all.
I think it's a network.
In which of the following clinical scenarios do ST segment depression during standard exercise testing increase the diagnostic probability of significant coronary artery disease? A, a 56-year-old man with left bundle branch block and a family history of premature coronary disease. B, 45-year-old woman with diabetes and hypertension with left ventricular hypertrophy on her baseline ECG. C, a 76-year-old man with new exertional dyspnea, a history of cigarette smoking, and normal baseline ECG. D, a 28-year-old woman with pleuritic left-sided chest pain after a gymnastic class. E, a 63-year-old man with exertional dyspnea on beta blocker, digoxin, and nitrate therapies. That's question 14. Now, if we go to option D, a 28-year-old woman with pleuritic left-sided chest pain after a gymnastics class, the age range makes it very improbable, and the chest pain is pleuritic, so at best she will have pericarditis or pleuritis. If you go to B, a 45-year-old woman with diabetes and hypertension with left ventricular hypertrophy on her baseline ECG. Baseline ECG is fine, and the age range is not is a good one, but the comorbidities are worrisome. But the baseline ECG is still fine. We'll go to C. A 76-year-old woman with new exertional dyspnea, a history of cigarette smoking, and normal baseline ECG. A lot of risk factors here. The age is not on our side. Postmenopausal woman, exertional dyspnea, which is already symptomatic, and significant cigarette smoking. This raises a red flag for being the answer. But let us go to A 56-year-old man with left bundle branch block.
Okay.
Hello? Hello?
Hello,
Yes.
You're welcome, ma.
Thank you. I was hearing you. I was locked off, so I wouldn't know when last you guys heard me.
So, and just take the question again or something. We'll get it faster or something.
Okay, I've explained A, B.
Okay.
And why, yes. I've explained A, why A and B might not be the correct options, and I've said why. I don't know if you heard me then. Can you hear me now?
I wonder if we heard you. Can you please take it just again, just a quick one?
I said in reporting, when we're reporting stress tests, that's when we have some background abnormalities on the ECGs, it's possible that it may alter what we are supposed to see actually. And I've mentioned conditions like, if you look at option A, in a patient that has that's had left bundle branch block, might alter the readings on a treadmill. That's the stress results, because we expect that there will be T-wave changes with LBB. So we might not be able to report the results accurately. So it will affect the diagnostic probability. That's for A. Other conditions too, like when we have left ventricular hypertrophy, I also said in left ventricular hypertrophy, we know patients with left ventricular hypertrophy could have concurrent strain too. And in that strain, we have ST segment depression with unequal T-wave inversion. That can also mar our reporting of the stress ECG. Then going to D now, I will hold on with C. So for D, a 28-year-old woman with pleuritic left-sided chest pain after a gymnastic class. We already know that the probability, like we've explained, has a very low probability in this instance. Is a young woman. There is possibility of a musculoskeletal pain here as a cause probably of the pain here. So that might actually affect our diagnostic and probability, because if we get like a positive here, if we actually subject this patient to a test, we might get a false positive test, which might not be the appropriate. So D is also a wrong option. Then E says a 63-year-old man with exertional dyspnea on beta blocker, digoxin, and nitrate therapies. As we know, digoxin has we have digoxin effects on ECG tracings, which will include the ST segment depression in sense of the reverse tick sign, which will actually also affect our reading of the stresses. And also when we use a beta blocker, when we are doing a treadmill test, will affect the percentage heart rates that the patient could attain. We actually request that patients who are on beta blockers should be stopped prior to or to stress ECG. So that will, because it will affect diagnostic accuracy. And also nitrite Nitrates, actually, we know what it does. It will allow vessel dilatation, and would also affect our readings here. We will not get the true picture of patients who should have a positive result. So the answer here, I feel, should be C, which is a 76-year-old woman that has risk factors, and also baseline ECGs are normal. Thank you. Don't know if there are comments and clarifications. Okay. I don't know if I can move on to the next question because of time.
Please do. Please move on.
Okay.
Thank you.
Question 15. Question 15 says, which of the following statements regarding cardiac catheterization is true? 15, which of the following statements regarding cardiac catheterization is true? A says the risk of a major complication from cardiac catheterization is 2.0% to 2.5% risk. I'd say that's actually a false, because the risk is lower than that, less than 1%. Sorry, I might not be able to quote the exact, but it's actually less than 1%. Is some around 0.1, depending on the particular complication we are talking about, and the type of patient. So that's why most times we screen patients well before actually subjecting patients to invasive procedures. But the risk usually for catheterization is low, usually less than 1%. Then B says the incidence of contrast-induced nephropathy in patients with renal dysfunction is decreased with intravenous administration of mannitol before and after the procedure. That's a false. It's the other way, because mannitol will dehydrate the patient more. So is actually in renal dysfunction, we are supposed to rehydrate the patient and do some other things before, not give them diuresis that will make them dehydrated. So B will be a false. C says high osmolar non-ionic contrast agents demonstrate a reduced incidence of adverse hemodynamic reactions compared to low osmolar ionic contrast agents. That also will be a false, because it's supposed to be low osmolar non-ionic contrast agents that should demonstrate reduced incidence, not high osmolar. So part of the prevention of nephrotoxic, contrast-induced nephrotoxicity is actually to use low osmolar non-ionic contrast agents in those who have high risk of toxicity, not high osmolar. So C is false. E, I'll go to E. E says retrograde left-sided heart catheterization is generally a safe procedure in patients with tilting disc prosthetic aortic valve. Actually, that would be a false, because in unlike in ball and socket prosthetic valve, in tilt valve, we could have entrapment of our catheter, which makes the procedure unsafe. And also we could besides the entrapping, there could also be trauma or what do you call it? Thrombus formation. Yes, increased risk of thrombus formation in this type of disc as compared to the ball and socket. So it's generally not safe. The retrograde generally not safe to do that in patients who has prosthetic aortic valve. So I will pick that as a false, although I might need more explanation on that.
So the likely correct answer will be D. I haven't ruled out other option, which says that the 1 French units, a measurement of catheter diameter is equivalent to 0.33 mm. Thank you. Because I will need clarification on the option E. Thank you. Comments, please. Okay. Dr. Adeyanju, please, am I audible?
Yes,
Yeah.
thank you.
You can move
Okay.
on.
So I should move to the next question.
So, Chief,
Yes.
before you move on, I wanted to ask a question. It may be like a foolish question, but I wanted to ask, what do they mean by retrograde left-sided heart catheterization? I don't really know what that is. To understand, because I needed to understand
That was what
why.
I was saying. I needed help, but let me say what I know about that. In heart catheterization, we either go through it can be either right or the left side. So in the right side, you are going from your preferably from the maybe brachial or the radial. You go through the right side of the heart. That's the superior vena cava, the right atrium, the right ventricle. That's right heart catheterization. So you can actually make a puncture through that's a VSD puncture, septal, that's the intraventricular septum puncture, then go through that and get to the left ventricular outflow tract, then to your aorta, to get through the sinuses, that's the right and the left, as the case may be. Then you can now go the other way. If you are not going through the right, go through the artery now. That will be the one I just explained first, is going through the vein, because you are going through the superior vena cava or inferior vena cava if you are going through the femora. But if you are going, you can go through the artery. So if you are going through the artery, that means you are getting through the left side of the heart, through the ascending aorta to the left ventricle. So you are going the other way around. That's retrograde as against anterograde. I'm not sure if that explains it. So those are the two assets that you can take.
It does. It does.
Okay.
Thank you.
Yeah. Thank you.
Okay, so just to add something little, I think she said it was usually when you want to assess the left atrium, you tend to do transseptal puncture. So you puncture, you go through the femoral vein, then you puncture the septum, and especially for procedure where you have to do isolation, posterior vein isolations, or radio frequency ablation, not the rest. Ability procedure, or you want to do some other procedure where you have to get to the left atrium anyway, you go through the septum. So that's the usual one. But so sometimes which you said anterograde, so sometimes you want to go through instead of doing that, you don't want to puncture the septum. You want to just go through the what's it called now? The AV valve, the aortic valve. So you just go through the aortic valve, ventricle, and then you go through to the left atrium. So that's retrograde. Okay, you're going against the flow. So the question here is trying to say that, is it safe if a patient with teething this prosthetic aortic valve? It's not safe because it's going to be trapped. Okay, your wires and all that's going to be trapped, and then you're going to have difficulties and you may, that valve, just have problem with the valve. So that's what they're trying to say. Going through the left ventricle down to the left atrium instead of the usual one, which we do usually, so puncture the interatrial septum. Thank you.
Thank you so much, Chief. Thanks for the clarification too. So I think I'll just move on to question 16. 16 says is 70. Okay, a 75-year-old woman was brought urgently to the cardiac characterization laboratory in the setting of an acute ST elevation myocardial infarction. She had presented with chest pain, epigastric discomfort, and nausea. Physical examination was pertinent for diaphoresis. Heart rate was 52 beats per minute. Blood pressure 85/50. Jugular venous distension was present, and slight bilateral pulmonary rales. Coronary angiography demonstrated ostial occlusion of a dominant right coronary artery. So, which of the following statements is correct? Which of the following statements is correct? A, isolated infarction of the right ventricle without left ventricular involvement is likely. B, ST segment elevation in late V1 and V2 will be expected to accompany inferior ST elevation. C, the abnormal heart rates and blood pressure are likely a consequence of vasovagal stimulation. D, ST segment depression is expected in the V4R. So I'll start from D. Oh, okay, let me just say this scenario, if you noted, is already patient has classic symptoms of acute coronary syndrome post the chest pain, and the angina equivalents were present in this patient. And looking at the heart rate is 52, of which acute coronary syndrome we expect to have tachycardia, but we are having the pulse low. It gives a suspicion that we have probably affectation of the SA node, as the case may be. And also blood pressure is low with elevated JVP. However, just had slightly pulmonary rales. So in this question said, we'll be looking more that the patient has a right coronary artery affectation, and as we've known, we've already talked about it, of the areas of the heart that are affected, and vis-a-vis some ECG changes that we're going to see. So this option D, ST segment depression is expected in the V4R. That would be a false, because in on the right side, V4 on the right side, we expect an ST segment elevation, like we have mentioned earlier. Then I'll go now to, okay, let me pick option A. Option A says isolated infarction of the right ventricle without left ventricular involvement is likely. The answer will also be false, even though most of the patient's symptoms point to majorly a right-sided, but still has some rales too. And again, really cannot say, depending on the dominant artery here. So we can really not say it will be strictly isolated right ventricular infarction, because you can also have affectation in right coronary artery. Like you said, you can also have affectation of the inferior segments of the left ventricle, as well as affectation of the posterior, yes, of the left ventricle. So to say that just the right ventricle that is affected would be false. Then now to B. ST segment elevation in leads V1 and V2 will be expected to accompany inferior ST elevation. That will be a false, because what we expect to see will be ST segment depression, like we have said in the anterior leads, which is what we are supposed to see when we have right ventricular infarction. So it will be an ST segment depression. Then when we now do the right-sided leads, we'll get the ST segment elevation that we're supposed to get in the leads. So the correct option here should be C, which says abnormal heart rate and blood pressure are likely to be a consequence of vagal stimulation, which will be true in this case. Other things that could also cause the bradycardia, as well as the bradycardia in this setting, could be affectation of the SA node, like I've said, which is supplied in most about 65 to 70% of cases by the right coronary artery, and also if we have affectation of maybe the AV node too, which in most cases is also supplied by the right coronary artery. So I think the correct option here should be C. Thank you. So I don't know if there are clarifications or additions to what I've said. Thank you. Will I hit the ground running so that we can finish to question 20 this night?
Go.
Okay, question 17.
Oh.
Question 17. Sorry, am I the one not seeing it? So I should use. Should I just read? I'm not seeing. Okay, thank you. So question 17 says, using Doppler echocardiography, the following values are obtained in a patient with a restrictive ventricular septal defect and mitral regurgitation: systolic transmitral flow velocity of 5.8 meters per second and a systolic flow velocity of the site of the VSD at 5.1 meters per second. The patient's blood pressure is 144/78. The estimated right ventricular systolic pressure is, so we are meant to calculate what the RVSP will be in this case. Restrictive VSD, that means the flow is actually still, or in most VSD, if there are no ensymega, the flow should be from the left side to the right side. And in calculating pressure, as the case may be, where the easiest way, from what I checked, would be using the modified Boreli's equation, which will be the 4 sir? Hello, sir. Okay, which will be 4 v squared, where v is the velocity at the at the tail, at the tip of where the direction of the flow actually is to. So like I've said, if you're looking at the values that we were given, ideally we expect that all things being equal, the 5.1 for VSD. So that means that's the flow from the left ventricle to the right ventricle. Yes, which is where we want to calculate the pressure. And it should also, like, it should, how will I explain it now? It should correspond, or should be like a an indirect measure from what we have as the systemic blood pressure in this patient. So we're given the blood pressure as 144 and the flow across the mitral, we are giving flow across the mitral valve as well as the flow across the VSD. So if we are to do that using the 4D squared, the calculation, sorry, I will need let me just use my phone. So the calculator, calculating that flow 4D squared, if 5.1 squared multiplied by 4, we give around 104 millimeters of mercury. Okay, so if that gives 104 millimeters of mercury, and we're already, okay, that would be the output from the, we now want to link it to the output from the right side. I hope I'm not complicating issues. We are looking at the output from that's the left ventricular outflow and also the right ventricular outflow. So it should actually be the same, all things being equal, if there are no regurgitation at both ends. So, but the regurg that we have in this instance now will be the shunt that we have from the left ventricle now to the right ventricle, which is the shunt that we have. And we've been given the gradient across that shunt. So if you calculate the gradient across that shunt, which is 104, so to get the pressure on the right side, we'll subtract the pressure from the gradient of the shunt that we have from the systolic pressure, which is 144 that we have been given. So if we subtract that, we'll have around 40, if I'm correct, as the correct answer here. So the correct answer should be C, if my calculation is right. I don't know if I've made some sense. Please, do we have clarification, comments? Please, did I communicate, SARS and Ma?
Yes, you did. I think it's
okay. It's clear. So I should go to question 18 now.
Yes, if there's no other question, I think so.
Okay. So question 18. Question 18 says, a 68-year-old woman with a history of diabetes and cigarette smoking and previously normal cardiac examination is admitted to the hospital with a new onset shortness of breath with exertion and orthopnea. She described having experienced a muscle ache in her anterior chest 10 days earlier that lasted several hours and has not reoccurred since then. Her blood pressure is 109/88. The heart rate is 102 beats per minute, and she's afebrile. The examination reveals an elevated JVP, bisal crackles, and pedal edema of both ankles. On examination, there is a grade 2 early systolic murmur. Grade 2 early systolic murmur between the left sternal body the ECG cardia with inferior Q waves that were not present on a tracing 6 months earlier. The chest
Hello, Dr. Malade.
Hello?
Yes, your network is a little bit unstable from my
Is my network? I think it's from my end. Is my network?
Okay, please,
The
can
call
you
is coming in that is disrupting my.
Okay.
Sorry. Okay, so I think I'm on now, if you can hear me. So yes. I said the ECG reveals sinus tachycardia with inferior Q waves that were not present on the tracing 6 months earlier. The chest X-ray is consistent with pulmonary edema, and she's admitted to the hospital, and a transthoracic echocardiogram is obtained that is technically limited due to her body habitus. It reveals a left ventricular ejection fraction of 60 and inferior wall hypokinesis. The mitral valve is not well visualized, but appears thickened, and there is an anteriorly directed jet of the mitral regurgitation that is difficult to quantitate. A diuretic is administered. Which of the following is the next most reasonable approach in our management? This question is quite long, but the understanding is that this patient had a feature that looks like a previous MI prior to presentation, and patient now presenting with complication of the MI. And looking at the clinical scenario, looking at where the jet is and the murmur is, we're told that the murmur is at the lower, auscultation. Yes, the murmur is an early systolic murmur that is present at the left sternal border. So an early systolic murmur present at the left sternal border, and we're also told that on echo, they saw the anteriorly directed mitral regurgitation jets. So I want to say maybe it's a mechanical complication from the previous MI, considering the fact that Q waves were seen which were not present in patient's ECG earlier, and the symptoms the patient is having is suggestive of a mechanical complication from the previous MI. And the one I will pick with the location of the murmur that we're given is between two things, either a VSD or a mitral regurgitation. So for a VSD murmur, which could actually complicate myocardial infarction, we expect an although it should actually be a pansystolic murmur present at that location that was described. So being an early systolic murmur at that point, if I would want to think maybe it's affectation of the papillary muscle, and the since the jet is directed, said the jet was directed, regurgitation jet was directed, when anteriorly. So if it's directed anteriorly, it will be affectation of the posterior muscle, that's the papillary muscle, that will be affecting the posterior the posterior leaflets of the mitral valve. That will be the posterior medial papillary muscle, as the case may be. But if the jet were directing maybe posteriorly, I'll be thinking of affectation of the anterior mitral valve in the sense, which would be the other papillary muscle. So that's just what the question is talking about for our understanding. So now going to the answers, it said urgent coronary angiography with planned percutaneous coronary intervention. I would say that would be a no, because it's not be an urgent one again. Patient already has a Q wave, which shows there is already transmural and there is necrosis already. So if at all we need any, it will be like is it rescue? Sorry, it would be like a sorry, it's not a rescue PI. Rescue PCI should be after. There's one third one I've forgotten, but not an urgent one, as the case may be, because it's no number and acute setting. Patients already develop complication, and we have to manage the complication. Option B says nuclear stress testing to evaluate for ongoing ischemia. That would be a no, because the patient already has an acute mitral regurgitation, so it's a contraindication to stressing the patient. Option C says transesophageal echocardiography and surgical consultation. I'll come back to that. I feel that should be the correct option. Option D says initiate long-term management, such as aspirin, angiotensin, AC inhibitors, as well as beta blockers. That will be a no now, because even patient would have developed acute pulmonary edema, which a beta blocker will be contraindicated. So that will not be a correct option. E, urgent right heart catheterization to evaluate for a left to right shunt. Yes, like I've said, I've ruled out the differential that is not likely to be a VSD. So I'll go more, the correct option should be C, which is urgent surgical consultation for the repair of the mitral valve that was affected. I don't know if there are comments and contributions, please.
Which option is urgent surgical repair again?
That is option C, sir. Surgical consultation and transesophageal echocardiography. I guess probably would be right to assess the mitral valve very well, which patient had a poor echo window. Yes, I should mention that. So we need transesophageal, which you can do intraoperatively too. That would be my submission.
Okay, please. Yeah, can you recap what you said about papillary muscle involvement and the direction of the jets?
And okay. Usually, when we have, because of the positioning and the valvular and the structures of the valve, specifically talking about the mitral valve now, when we have affectation of the anterior mitral valve, the direction of the jets would be posteriorly. But when we have affectation of the posterior mitral valve, the direction of the jets will be anteriorly. And the papillary muscles that's attached to each, they are different. So we have the posterior medial for the posterior, if I'm right now, and we have the anterolateral for the anterior. Those are the then other subvalvular structures. So if during a myocardial infarction, they have affectation, like I guess in this case, which was the posterior medial and papillary muscle, and we have the jets directing anteriorly. That's when we're hearing the murmur was more to the side that it was. If it were directed posteriorly, the murmur will radiate to the axilla. I don't know if you got that. Is that clear, sir? I don't know if there are clarifications and addition.
Okay. Yeah.
Okay.
Thank you.
Thank you. So should I still run? Question 19. Can I continue?
Please go ahead.
Okay, thank you. Question 19 says, which of the following statements regarding altered electrolytes and electrocardiographic abnormality is true? Okay. Option A says hypokalemia causes peaked T waves. Hypokalemia causes peaked T waves. That's actually would be a false, as we know, is hyperkalemia that will cause tau-tented and narrow T waves, not hypokalemia. Then B says hyperkalemia causes QRS narrowing and increased P wave amplitude. Hyperkalemia causes QRS narrowing and increased P wave amplitude. That would be false. In hyperkalemia, like I've said, there is narrowing and tau-tented T waves, and depending on, let me put it like, depending on the severity of the hyperkalemia, it progresses. So the first thing we'd see would be on the right side, that's the T segment. You see narrow, tall T wave. Sooner or later, we could have the flattening of the widening of the KRS complex. Sorry. Then we later see flattening of the P waves, and no, I think flattening of the P waves first before widening of the KRS complex, and sooner or later we have what we call the sine waves before the patient goes into asystole. So that makes option B false. So option C. So option C says hypomagnesemia is associated with monomorphic ventricular tachycardia. Well, hypomagnesemia with some other abnormalities like hypokalemia and the rest would rather give a polymorphic VT, which leads to torsade de points rather than a monomorphic ventricular tachycardia. So I think C2 will be false. Then D, hypocalcemia causes prolongation of the QT interval. That will actually be a false. It's hypercalcemia that causes prolongation of the QT interval. I think that's a point we really need to take note of as against what we will think that maybe hypo will cause prolongation of QT interval. So hypercalcemia, not hypocalcemia, is what we cause QT prolongation in that wise. So that makes option D true. Then option E says severe hypocalcemia has been associated with prevalence of a J wave. J wave actually, and that's the Osborne weight, is seen more in hypothermia. So it's hypothermia that gave more of these Osborne waves, not severe hypocalcemia. Severe hypocalcemia, not sure we really have any ECG abnormality with that. But another thing that I would just like to mention, if in the setting of let me just put it like Osborne wave or something that looks like an Osborne wave, which is the notch after the QRS complex at the J points, like a notch, that's the Osborne waves. You can also see something similar in benign early repolarization, and in that wise the QT interval will be normal in that wise, and it will be in that wise to be called a fish hook sign as against the J wave, the Osborne wave in hypothermia, which could be associated with prolonged QT interval. Thank you. Don't know if there are additional comments and clarifications, please.
Please continue. If there
Okay.
are no
All right. Thank you. So now to the last question.
Sorry, Doc. You said 19 hypocalcemia doesn't cause prolonged QT. Don't know if I heard well.
No, okay. I was trying to explain in case they could face these questions in another way. That this J wave, which is
for D, I'm talking about the D option. The D option.
Okay, D option.
19.
Okay, it's supposed to be. You said what?
No, I thought I heard you said hypocalcemia doesn't cause prolonged QT.
No, hypocalcemia. I think that's the correct option there.
Okay, because I thought you were saying hypercalcemia.
Yes,
thank
does
you.
not
Sorry.
really have.
Sorry.
Yes, okay.
Thank
sorry,
you.
That was a slip of tongue if I said that.
You.
I'm sorry. Okay. Sorry about that.
I probably think I just need to remind that Osborne wave could be a normal variant, especially in blacks.
Yes. So that's what I was trying to relate to benign early repolarization, and it will not be associated with prolonged QT interval as against the one we see in hypothermia that could be associated with prolonged QT interval. So in that way, it will be called maybe Fish-Hook sign, or some people take it as a normal variant. So in case we see something like that in exam. Thank you. So can we move on so that we can close?
The
last question. Thank you. So the last question says, question 20. A 46-year-old woman with progressive exertional dyspnea who recently found to have bilateral alar adenopathy on chest X-ray and first-degree AV block on her ECG. A transbronchial biopsy demonstrated non-cassating granuloma consistent with sarcoidosis, and she's referred to you for assessment of cardiac involvement. Which of the following statements is true regarding the diagnostic evaluation of cardiac amyloid and sarcoidosis? The diagnostic evaluation of that. So option A says left ventricular regional wall motion abnormality in sarcoidosis are typically present in coronary distributions. Because of time, I will just be answering as I'm reading the options. That will be a false. In sarcoidosis, we expect patchy affectation, not following a coronary artery territory distribution. So A is false. B, that also applies to most other infiltrative diseases like amyloidosis, Fabry's, in case we see questions like that. So most infiltrative diseases do not follow coronary distribution pattern like in coronary artery disease. So B says an elevated serum angiotensin converting enzyme level has low sensitivity but high specificity for the diagnosis of sarcoidosis. That would be a false. I don't think it has a high specificity. We could have elevated serum ACE enzyme level in some other disease conditions. However, if this is present, it raises the suspicion of sarcoidosis vis-a-vis other clinical and radiological examinations that we could pay. So C says sarcoid associated late gadolinium enhancement on cardiac magnetic resonance imaging is usually localized to the endocardial border. That would be a false. Is usually to the myocardium, not the endocardial border. And also when present, is usually specifically located at the base of the left ventricle. That's the at the base, yes, yes, at the base, let me put it that way, of the left ventricle, both laterally and also at the both laterally and also at the let me say inferior aspects. So it's usually at the base of the, and usually involving the myocardium, not the endocardium. So I think that will be false. Then D says fluorodeoxy glucose uptake of cardiac PET differentiates active cardiac sarcoidosis from inactive scar tissue. That is actually true. the PET scan, what the PET scan does is to helps us to know the areas where we have acute inflammation, which will actually mean disease activity in this patient. And it's the PET scan is said to be used to monitor progress of treatment in some disease conditions, in this case for sarcoidosis. If there is area of high uptake, for instance, it shows that there is high activity and inflammation around that side, means and we can use it. So as the high uptake, as the uptake reduces, it shows that patient is getting better. And if there are no areas of uptake at all, it will mean that there's no active disease in that spot, and it's just a scar that we are seeing. If we are to relate it to what we learned at the beginning of my presentation, that's from question 11, comparing the SPECT to PECT, like Dr. Quickie or Oladimeji had explained to us. So it makes it clearer. So why for SPECT, we are looking at the that's the contractility, actually the motion, the function, if there is dyskinexia, and there's a part that is not functioning well. Let me put it that way. But for PECT, we are looking at the disease activity. So uptake in this wise will mean increased inflammation and increased uptake of glucose and the likes from the area that we are seeing, which will mean that the disease is actually still active. Or like if there are no uptake, it will mean that it's just an area of scar. Patients might be in remission at that time. So I think option D will be the true answer here. Thank you. Thanks for your patience and for allowing us to go through this. Don't know if there are questions, clarification. Am I still audible?
Thank you very much. Thank you.
Yes, thank you. I'm done with my question. Thank you for allowing us to go through this despite the overshooting of the time.
Thank you. We're supposed to, it's past 11, isn't it? I thought it's 10:30. Okay.
No, it's past 11. I just wanted to see if we could rush to
I
finish.
think it's time different. I was thinking of 10:30, but that's a great one. I think this is a good start. I must thank Dr. Zoke and Adeyanju for stirring the soup for us tonight, and every person that showed up, thank you. Again, I always say thanks to Prof, the copy, and every other person that made today possible. Please, let's keep up with this spirit. I'm sure if we can keep up with this commitment, we're going to achieve a lot. In my own experience, the more you discuss cardiology, the more you increase your confidence. So let's continue to talk cardiology. Prof, are you still here? If you're here, any final words before call it tonight? Prof? Okay, copy.
All right, thank you, Kweki. Thank you, everyone. I'm so impressed by this this badge, man. I'm sure with this level of commitment, we're going to do a whole lot within the next 1 month. This is the first time, I don't know, since we started, that the first meeting in the group extended to almost 12 midnight. So thank you so much, Dr. Zoke and Dr. Temilade, for an impressive start. I think we'll come again tomorrow.
Yeah.
Up to almost 11:36, there are about 39 persons still on the call. So thank you so much, sir. Thank you, Kweki, for all the explanation. Thank you.
Thank you. Thank you. And then Dr. Zoke and Nadia, any announcement?
Just a request, sir.
Okay, sir.
We had thought that given the shortness of the time that is available now, we should start using Fridays and possibly Saturdays. We're probably trying to encourage our members to be more, to work more on their parts, such that if we can take up to 50 questions, then we should be able to finish this in 2 weeks.
Exactly.
If possible, we can come back to it and do a revision on it again. That makes it stick better. Then essentially that. But I don't know whether it is late, whether everybody has slept now, whether we should make those raise those discussions tomorrow when we are starting and everybody is still fresh and awake. Yes, sir.
Okay, so we can start early. I think the most important people to be part of that decision are those going for exam in March, as we are told tonight that the exam is 9 March. Once you guys agree, all of us will just follow. Who cannot show up can take a break, but as long as you guys stick together, that's the most important thing. You're the one going for exam, to be frank. So if you even want to extend this meeting until 1 a.m.,
it's up to you. I remember the first batch when we were sometimes we stayed till 1 a.m., 2 a.m.
Yeah, that's still 1 a.m. So we
But-
make it so because it's your exam so that you can catch up with a lot. It's
a
quite
whole lot.
There's a whole lot. So we don't want to regiment it that must be because we know if you do it like that, you won't catch up. Because I've gone through the process, Okopia have gone through the process, all of us have gone through the process. The whole lot within a short time. So if you want to make extra time, fantastic.
And the truth is, the moment you finish Braunwald, even you feel like there's something about cardiology that will just look like that's been demystified. So just the way you said, just target finishing Braunwald, why other tips will be coming up in the process. So if you want to do Saturday, why not? But I would still advise that even when you guys discuss, you still have some time where you have your personal reading, once in a while. But if you want to do Saturday, Sunday, why not? It's you people that will determine how we go.
Thank you very much, sir. Maybe we'll bring that later in the house then for discussion.
First thing tomorrow for discussion, yeah. All right, thank you, Adeoju, Olumolade, everyone that presented tonight. Thank you. Good night. See you tomorrow. Bye-bye.
Thank you, Chief. Good night.
Thank you, Chief, Professor Ladimeji, everybody. Chief Kweki Okopi, good night.
Dr. Okopi. Chief Okopi.